Hello. Hello guys, am I audible and visible? If so, just give me a hi. Hi Sahil, how are you? I hope I'm audible and visible. These ads are irritating, right? Hello Mithali, good evening. Good evening everyone. Like I said, I hope I'm audible and visible. The session specially for the upcoming FMG exam by June, and I'm going to go live since I know you guys already read it, and this is going to be a quick revision for you guys. So if you're ready for the game, and let's start and let's learn more together. I'll have few approaches in systemic pathology and hematology, and few topics, few things which you have to unfortunately memorize in your general pathology. Fine. Okay. So the first slide here, I've given the PDF in both the WhatsApp group and the Telegram channel. You have the PDF. You'll have the questions as well. If you use a software like an iPad or a Surface Pro to write, please scribble whatever I do. I'll give you the annotated PDF also, but I feel that it's always best if you write on your own. Fine. Okay. I'm audible, right? If so, just give me a hi. Sure, Deepa will do it. So these are the topics which are important for your FMG exams, the upcoming ones. Like if you can see, these are topics curated from the past 4 years of FMG PYQs. So quite a few questions have come on cell adaptations, which means your cell, your hyperplasia, hypertrophy, metaplasia, atrophy. The intracellular accumulations of the pigments, the calcifications, the protein, the fatty change, and everything. Inflammatory mediators is a very, very favorite topic. There's nothing conceptual to remember about it, right? And here, sure, Deepa, tell me whatever you're not understanding. I will try to talk in Hindi, fine. And the inflammatory mediators, it's nothing conceptual, like I said, it's about memory. You will definitely have to read them. I have put genetics as well as a little bit of CNS lesions in red, because what has happened over the period of time is, if you carefully observe, there's not much of questions in genetics, right? It's a very, very basic one. And a little bit about CNS also has come, very, very basic one, right? Hello, Namaste Medico Forever. Manoj, yes, you'll get the NEET PG videos on April 1st, just a couple of days from now, right? Hypersensitive reactions, on the other hand, is extremely important. Almost every exam has at least one question on hypersensitive reactions and autoimmune disorders as well, a little bit, fine. And clinical effects of cancer. Cancer is neoplasia is very, very vast. You don't read neoplasia just from your pathology alone. It's medicine, it's surgery, it's obstetric gynecology everywhere. And little bit clinical information on cancer is definitely there, fine. Okay. Nazamuddin as well as Deepa, tell me what you're not understanding. I'll definitely reply in the way you can understand it. Fine. Okay. Medico, just if you have time, free time, you can just listen through it. Fine. Hematology, predominant of the questions are common iron deficiency anemia. That's very, very good, which I feel it's the best way to learn medicine. Apart from your hemolytic anemia, your thalassemia, your sickle cell anemia, your spherocytosis, those are required. Fine. Images, I'll definitely have a beautiful flowcharts of how to identify all the inclusions. We'll definitely go through it. Fine. And the approach to leukemia and lymphoma, approach to bleeding coagulation is also very, very important. Fine. Okay. So PDF is there in the group. The questions are also there, and we're going to learn both together. Fine. And the systemic pathology, glomerulonephritis is one of the important topics. Apart from the lung tumors, GI tumors, vasculitis and the cardiac vegetation is also important. Fine. Okay. So with this note, I'm going to go to questions. I want you guys to answer the questions. These are going to be very simple questions. You guys know the answer, and I'm sure I'll display a question. I'll keep some time, then I'll keep on asking series of questions, because general pathology is about memory. So more and more and more we read, we'll definitely come to a very, very, very good memory, right? So I'm going to mute myself, keep quiet for the next 10-15 seconds. Tell me the answer. Deepa, you tell me the answer. Tell me what you're not understanding. We'll learn. Fine. Language is not going to be a barrier for medicine. It's going to be pink and blue. I'll explain with images. Even with mute, I can explain it. Okay, Sultan has gone. Rajendra, Medico Forever has gone with Barrett's esophagus. Medico, Barrett's esophagus is the question. What's the right answer? Okay, A, columnar. Okay, great. B, nice. Fine. So we have a different options here, right? So B is there, A is there, C is there. Great. None of you answered D. Great till that. Fine. So now it's a question on Barrett's esophagus. This is a very favorite topic for FMG exams. And here, all of you guys know about Barrett's esophagus. Tell me, what is the predisposing factor for Barrett's? Predisposing factor for Barrett's is very simple, right? It's going to be a GERD. Whenever a person has a chronic GERD, gastroesophageal reflux disease, the acid is going to go to esophagus. I'm just going to ask you a very simple question. What is the lining epithelium of esophagus? Normal lining epithelium of esophagus. Okay. The normal lining epithelium. Perfect. Normal lining epithelium of esophagus is squamous, right? Normal lining epithelium is squamous epithelium. So when I have a squamous epithelium normally and a drop of acid, your skin is squamous epithelium, right? Let's assume acid drops on your skin. What will happen to your skin? Skin will burn, right? Obviously, skin will burn. So when skin burns, I need to protect. So I need to protect the esophagus from your acid. So what I'm going to do is I'm going to secrete mucin. There'll be mucin secretion. So this is what nothing but the change, the metaplasia that's happening here, right? This is the metaplasia, fine. Deepa, it's Pathology by Ranjith AR. You can search that, fine. Okay, so that's mucin secretion which neutralizes them. Now let's come back to the question. See, because most of the MCQs, I want you to carefully observe and carefully know the topic, because when you learn something superficially, you might make a mistake. It's mucin secretion. That's a metaplasia here, right? So definitely squamous is not the answer. Squamous is normal there. Dysplasia is not the answer because it's metaplasia. Now when I look at the option B as well as option C, what does intestinal epithelium secrete? Am I right in saying that they secrete mucin? They do secrete mucin, right? They do secrete mucin. So my intestinal epithelium also is partly correct. Columnar epithelium. You guys know columnar epithelium has a specialized cell called as goblet cell, right? As a goblet cell. So obviously goblet cell in the columnar epithelium will secrete mucin, right? So here there are two different things here: intestinal metaplasia and columnar metaplasia. What will be the right answer? Right answer is going to be columnar metaplasia, right? This is an old terminology. I'm not wrong in calling it intestinal metaplasia. If you are born like 10 years back, if you have written the question 10 years back, intestinal metaplasia was the right answer. WHO has changed for the past 5 years. I have to report it as an columnar lined esophagus, right? I should not be calling it as an intestinal metaplasia. It's only columnar metaplasia, fine? Okay, great, perfect. It's not intestinal, though intestinal is partly correct. If you don't have the option columnar metaplasia, then please go for intestinal metaplasia, fine? Great. So there are a few quick things which I want you to answer. You'll have I hope you have the PDF, right? If not, just write it down here, fine. Here, the first thing, the most common metaplasia. I'll give you options, you choose. Which is more common, epithelial metaplasia or mesenchymal metaplasia? Which is more common? Epithelial metaplasia or mesenchymal metaplasia? The most common is obviously your epithelial metaplasia, right? So epithelial metaplasia is more common than mesenchymal metaplasia. Among epithelial metaplasia, again, I'll give you an option. You're going to answer. I want you guys to comment. Even if you are wrong, it's completely fine. We learn by making mistakes, right? Okay. Sultan, if both the options are there, the best option is going to be columnar metaplasia and not your intestinal metaplasia, right? Perfect. So if among the epithelial metaplasia, which is more common, squamous metaplasia of the respiratory tree or Barrett's esophagus, which is more common amongst these? Squamous metaplasia of respiratory or a Barrett's esophagus? It is squamous metaplasia. Among the epithelial metaplasia, the squamous metaplasia of the respiratory mucosa is more common. Squamous metaplasia of the respiratory epithelium, secondary to smoking, is more common than Barrett's esophagus. See, unfortunately, over the period of years, you have read more and more and more things about Barrett's esophagus, right? I'm sure you must have read. But it's a reality. See, whenever a most common question comes, think logically. Tell me which is more common, smoking or GERD? Every human being living in the world will know that smoking is more common, right? So obviously squamous metaplasia is definitely more common than your Barrett's esophagus, right? Whenever you have a problem in the most common, whenever you have a problem in memory, use logic, because logic helps you to remember it for a longer time than memorizing the fact, right? The stain used for Barrett's esophagus is also came in MCQ. We just now read that Barrett's will produce mucin. Can any one of you name stains of mucin? There are two stains of mucin, and I'm sure you guys both the stains you will definitely know. What are the stains for mucin? Great. There are two stains. Perfect. The first guy is Alcian blue. I would personally prefer Alcian blue stain because that's much more brighter and easily can be picked up, and also pH, right? It's positive for both Alcian blue as well as pH. Rajendra Yadav, Alcian blue for pH 2.5. I would say it's a bit on the higher aspect, but you're right. I'm not saying you're wrong. You need not go that much, right? Your methylene blue might not be helping me. Leukocidin might not be helping me. It's both Alcian blue as well as pH, right? pH of 2.5, great. If you don't know that also, it's completely fine, fine. There was a question which came amongst this. See, both are mucins, right? If the question says the mucin which will stain the acidic mucin, the stain for acidic mucin is Alcian blue. PAS will not stain acidic mucin. PAS will stain only the neutral mucin, right? Okay, perfect. Bladder stones. I'm having one more etiology here. Bladder stones also causes metaplasia. Obviously, the urinary bladder epithelium. What change or what epithelium will it change to? The normal bladder epithelium is transitional epithelium, right? So due to metaplasia, what epithelium will it change to? Anyone? It's just bladder mucosa. What epithelium, what metaplasia will happen? Perfect. They will have squamous metaplasia. Now I'm going to extrapolate a little bit of this. See, if you know the basics, you can extrapolate the normal, you can extrapolate the abnormality, right? Now I'm going to have Deepu Singh, please tell me what you're not understanding. I'll answer them in the language which you can understand, right? So in bladder stone, if you look at it, see, it's a chronic irritation of the bladder. Can I say there's a worm called a cystosomiasis, which also will cause chronic irritation of the bladder? It will cause chronic irritation of the bladder, right? Now, for me, when there's a chronic irritation of the bladder, which is going to result in squamous metaplasia, if I'm not able to remove it, can it become cancer? Metaplasia will become cancer, right? So tell me, bladder stone or schistosomiasis, if it becomes cancer, it will cause transitional cell carcinoma or squamous cell carcinoma. Because this is common in MCQ, especially not for bladder stones, the schistosomiasis, right? Both bladder stone as well as schistosomia hematobium will cause squamous cell carcinoma of bladder more than your transitional cell carcinoma of bladder, right? Those are the risk factor for your squamous cell carcinoma of bladder, fine? Okay, fine. So vitamin A, when you go with vitamin A, both excess of vitamin A as well as deficiency of vitamin A will result in metaplasia, fine? Okay, both excess as well as deficiency of vitamin A will result in metaplasia. Deepu, tell me what will I tell in Hindi for mesenchymal metaplasia? Where do you see mesenchymal metaplasia? Kahan dikh raha hai? You want this part in English? I can do that, right? It's simple terms. Mesenchymal metaplasia, it's a mesenchymal tissue. When I have mesenchymal tissue, the mesenchymal metaplasia, one of the classical examples of mesenchymal metaplasia is your, I'm sure you must have heard this, it's myositis ossificans. Myositis ossificans is nothing but your a classical example for mesenchymal metaplasia. You are having a muscle tissue changing to bone, one going to the other one, fine? Okay. Okay. So these are few pointers which I want you to remember in metaplasia. That's all, fine. So there are common things. You know what is metaplasia is a change, and metaplasia will definitely result in cancer, fine? Okay, great. Okay, let's come back. Let's come back and understand. Let's leave them. It's fine. If you're not understanding Deepa, I'll definitely help you. As well as Deepa, I'll definitely help you in understanding things. That's my goal as a teacher here. Fine. Okay, let's learn. Next question. Look at the question. I'll mute myself for a few seconds. Comment on the answer. It's a very, very simple question. I want you guys to answer this. Great. Sultan has started the goal. Sultan has said B. Medico Forever has said B. Great. Great. 83-year-old perinuclear pigment in the cardiac fibers. I have not given the color of the pigment, but still, this itself is a goal, right? 83-year-old means you're going to go for one guy, which is lipofuscin, which is your wear and tear pigment, pigment of cell aging, pigment of inflammatory mediators, everything, right? That's a classical one. Perfect. This is a pigment of aging. This is a pigment seen in your cell damage. This is also called as an wear and tear pigment. Okay. Can anyone tell me the color of this pigment? Yeah, perfect. Sultan has answered the question before even me asking. It's a brown color pigment, right? It's a definitely lipofuscin. Lipofuscin is a brown color pigment. Now I have few concerns here. What do you think is the color of option A as well as option C? Hemosiderin and melanin. What do you think is the color of hemosiderin or the color of melanin? Both of them are also brown in color. Iron again, iron deposit is nothing but hemosiderin, again brown in color, right? In other words, all the four options here are brown in color for me. So obviously, I will not be able to differentiate on a light microscopy whether it's lipofuscin or iron or melanin because everything looks the same brown in color, right? So when you have any pigments, obviously I have to have a stain to identify them, right? Rajendra Yadav, one change here, melanin is not black, melanin is brown in color. When it becomes very dense, it becomes like a hair, it's black in color. It's very, very dense, right? Normally, our skin is melanin, it's brown in color. Okay, when it becomes dense, it appears black in color, right? When I take pigments, there are two main colors which are important for me, both black as well as brown. Whenever it's black in color, almost always it is exogenous. Most of the black pigments are exogenous, which means they are not seen inside the body, they come from outside. Fine. Sure, Afsal. I'll definitely do that. I have shared it in the WhatsApp group of mine and Telegram group of mine. I'll definitely do things in future so that it reaches before. Right? So if you have anything black in microscopy, think of few things. One, coal. You had a question couple of years back. A person was doing esophagectomy, right? And there was an hilar lymph node which had extremely dark black color pigment on microscopy. There were two options, melanoma or anthracosis. It'll always be anthracosis because it's black on microscopy. Black is equivalent to coal pigment. It can be anthracosis, it can be coal workers pneumoconiosis, anything, right? Anything which is black in color, think of coal. There's one thing which is not exogenous but which is black in color, again primarily for an MCQ. Can anyone name the syndromes which are associated with jaundice? There are quite a few syndromes, right? I'm sure you guys know the syndromes. The nocturnal guy, that didn't happen at the sprint session. I'll definitely come to it soon, right? I'll take that sometimes down the road, right? The second one, it's one of them is your Dubin-Johnson syndrome. When you take Dubin-Johnson syndrome in liver, you'll have black color pigment. Keep this in mind. Again, these are the only two things which can be black in color. Dubin-Johnson, a congenital jaundice, which can cause hyperbilirubinemia, which can have a liver pigment, which can be black in color, right? The rest, every pigment in my body is brown in color only. Crigler-Najjar will not have any microscopic finding. Dubin-Johnson will have the black color pigment. Great, fine. So that's everything is brown. Like I said, your brown can be melanin. Melanin is brown. It's not black. Your hemosiderin is brown. Obviously, it's iron. Copper is also brown. And lipofuscin is also brown, right? So now my concern is I have to identify what is what. I have all these guys, everything is same color, everything is brown in color. I should be able to differentiate which is which, right? So I need special stains for that. Because in microscopy, neither you nor me can say this brown is different from this brown. Though your textbook will say golden brown, reality it's brown in color, that's all, fine. So for melanin, I have a stain called as Masson-Fontana. This can come in an MCQ. This has come in an MCQ. Masson-Fontana is a stain for melanin, right? Hemosiderin, I'm sure you know more than you must have read that more than I have done. Pearl's Prussian blue, right? And the positive color is blue. Copper, the stain is simple. There are multiple stains. I would prefer you at least to remember this Orsine stain. There is rhodamine, there is rhodonine. Like Sultan said, rhodamine is a very good stain for copper as well. Orsine, personally like it because in microscopy, Orsine looks much clear. Lipofuscin, I do have a stain for lipofuscin, but I'm not going to load. But one important fact, they are always in perinuclear location. If you have a perinuclear location, that's how lipofuscin looks, right? You have pearls, you have rhodamine, you have Masson-Fontana, and lipofuscin have the perinuclear location, right? So these are the brown pigments which can be seen in the body. Please remember this. See, these are basics. If you understand the basics, with the simple finding, you can diagnose hemochromatosis, you can diagnose Wilson's, you can diagnose sideroblastic anemia, you can diagnose iron deficiency anemia, a lot of them, right? Which part you want me to repeat, Deepa? Just can you tell me? This is a clue here. If it's perinuclear, the answer is going to be lipofuscin. I don't want you to be hell-bent on 83, the age alone. Because let's say I'm just going to ask you a question. Let's say a kid is born. A kid is born with a hepatocyte, right? When a kid is born with a hepatocyte, will the same hepatocyte be with the kid after 20 years old, or it will be replaced? It will be replaced, right? So lipofuscin is the pigment of cells aging, not the patient age. It's a pigment of cells aging and not the patient age. Don't misinterpret that. I can have lipofuscin even in a 10-month-old infant, because a cell, when it becomes old, it will accumulate lipofuscin. Fine. Okay, Deepa, coming back to your question. Black, there are two things. Most of the thing which is black in microscopy is coal. It's coal, it's carbon particle, that's all. If you have black in a case of jaundice in liver, think of Lewin-Johnson syndrome. Fine. That's the only thing about black. I hope it's clear. Fine. Okay. Next. This is a very simple one. I want you guys to answer. I know you will answer in a jiffy. Comment on your answer. I'll keep myself quiet for some time. After this, I'll show you a simple, beautiful animation on YouTube. YouTube is the best university, whatever I have seen till the past decade. Option? No one? There are two contradicting statements here. That's why maybe you are taking time to answer. Okay, I'll read through the question. Which of the molecules are required for loose addition of the leukocyte to the vascular endothelium in acute inflammation? Addition might confuse you, but the question is asking about loose addition. This addition is not the technical addition. Which of the following will help in loose binding? Loose binding is always pointing towards rolling. You have steps in inflammation, right? Diabetes, rolling, margination, everything. We'll just look at it quickly, fine? So here, one of them which is going to help in rolling is your selectins, which is option B. Like most of you wrote the right answer, right? If integrin was there in the question, some of you might have confused, but loose addition, when I take an English terminology, scientific terminology is equivalent to rolling. So my answer is definitely selected, right? Like I said, I'm just going to use a YouTube animation video for you. I hope this is visible. And that's, where is my cursor? In this here, if you look at that, maybe we'll go a little bit back. So normally when you have inflammation, the cells will be flowing in the center without inflammation. That's called as a laminar flow. But what happens is, whenever there's an inflammation, these selectins come up, right? The selectins is going to bind to the cell membrane of the WBC with a receptor called as Cialis-Lewis X receptor. Once it binds, slowly it rolls. Look at the selectin. All the green ones are the selectin. Slowly it rolls one by one. Since it is very loose, that's the reason it's rolling, right? It will roll till this place. If you can look at this place, it has stopped here, right? You can see that here it is stopped and it's going outside, right? It's going outside, it's going outside, it's going outside. I just want to pause here. Okay, I'll just pause here and we'll talk about few. Sorry. Okay. See here, we saw that the cell from here went outside and squeezed and went outside, right? So this process is called as diapedesis, right? I'm going to ask you a simple question. Tell me, in diapedesis, what is the molecule important in diapedesis? We had the options as well. We had PCAM, right? So PCAM is the one which is going to help me from the lumen to go outside, which is diapedesis. That's one molecule. The second is the most important thing. Every blood vessel is lying on a membrane called as basement membrane, right? What is basement membrane made of? Can anyone tell me what is basement membrane made of? Basement membrane is made of collagen, right? So my endothelium here will give gap, but my basement membrane is the yellow structure here. My basement membrane will not be destroyed. So what is required is, for diapedesis, there are two steps. One, the cell here will release collagenase. The neutrophil granules are collagenase. They release the collagenase, destroy this yellow color basement membrane. Only then they can come outside, right? There are two steps in your diabetes. Please remember that, right? So once the diabetes is there, automatically it goes outside. These are the chemotactic factors. Based on the chemotactic factors, this is in real time. Look at this. The cell is rolling. You can see the cell rolling. Slowly it rolls, keeps on rolling here. It stops and it slowly comes outside, right? There are multiple things. On top of it, also you can see the cell rolling closely. It squeezes outside and comes outside, and this goes to the site of inflammation, right? Okay. I'll just come back to our original class here. That's a very simple animation of your inflammation, right? Inflammation is very, very beautiful, right? Just to make things clear, I'll just write all the required things for us. I have something called as a margination. Margination is the first step because we just saw that all these cells will be in the center. Margination is something which will go to the corner, right? So for margination to happen, I need two guys. Margination is primary and vascular phenomenon. I want you guys to answer here. What is this change in the vessel which happens after inflammation? Normal or dilated? There will be vasodilatation, right? Normally, let's imagine a river. River is going normally smoothly, laminar flow. There's a branch, dilates. It will become turbulent, right? That turbulence is what? When there's dilation, the turbulence makes my cell go to the corner. That's margination. But selectin helps because the turbulence. So what happens is it will come back to the center. Right? So for margination to happen, it's a primarily a vascular phenomenon, and obviously selectin helps, right? I don't have any disease when margination fails. We'll go through the disease part whenever there's a disease. Fine, perfect. So next step is rolling. It has come to the corner. Like we saw, there were selectin molecules. It has to slowly roll through it, right? For rolling, I need two molecules. One is sialyl Lewis X receptor, which binds to selectin. In this, I want you to write here, in WBC, I'll have sialyl Lewis X receptor. Because I want you to remember, if I have a problem or defect in WBC, right? You are going to name the disease, right? We'll not memorize the disease, we'll name the disease. I'm saying I have a disease where my sialyl Lewis X receptor is not there, congenitally absent. Will the leukocyte adhere properly or not? Adhesion means I'm not talking about the technical adhesion, normal English adhesion. Will it adhere to the vessels or not? If sialyl Lewis X receptor is absent, they won't, right? So can I call the disease leukocyte adhesion deficiency? It's a very simple terminology, right? They don't adhere if the sialyl Lewis X receptor is absent in the WBC. It's a problem of the WBC, right? So I have a disease called as LAD2. LAD2 is defect in rolling, defect in, I'll write SLEX for sialyl Lewis X, right? It's a very simple thing. If a problem is in WBC, it's not going to adhere, that's all, right? Next is adhesion. We saw that it rolled and stopped in a place. It then has to squeeze out it. For adhesion, I need few more guys. I need something called as integrins, and I need one more guy called as CAMs. CAMs stand for cell adhesion molecule. Again, for us to remember, on the WBC, I'm going to have integrin. If the integrin is defective, am I right in saying that they don't move outside? They can't move outside because adhesion is going to be a problem, right? That's your LAD1. Okay, LAD1, LAD2. I'm not a fan of mnemonic, but maybe write LAD1 as I. So just you remember, LAD1 is for integrin. And LAD2, please remember, it is not selectin, it is sialyl Lewis X, because the problem should be in the WBC. Then only I can call it leukocyte adhesion deficiency. You can make a mistake here. You might call sialyl Lewis X, fine? And go to diabetes. Diabetes, like I said, there are two things required for me. The first guy is PCAM1, right? The other guy is your collagenase. I need both of these. Only then it can go outside, because basement membrane should be damaged. Only then WBC can exit, right? Next is phagocytosis and killing. This part I'll explain in this separate thing, right? So now my phagocytosis happened. So all the way by which the killing is going to happen inside the WBC, we call it respiratory burst. The term respiratory used because it's oxygen dependent. That's all. You have oxygen. Can anyone tell me what is the enzyme which will be involved in the first step of respiratory burst? I have oxygen as an enzyme called as perfect NADPH oxidase. So this NADPH oxidase will convert oxygen into O2 minus, which is called as superoxide. So when I have superoxide, whenever there's superoxide, it will be converted by an enzyme called as SOD, superoxide dismutase. Right? I'm going to have a superoxide dismutase, right? Great. With the help of superoxide dismutase, again, that's an enzyme which you know, it becomes hydrogen peroxide. When it becomes hydrogen peroxide, with the help of a classical enzyme called as MPO, never ever forget that MPO is a marker of neutrophils. Always remember, even in leukemia, I want you to remember that, right? And fluorine. With the help of it, it produces HOCl. See, this is an MCQ. HOCl is most effective bactericidal. Little bit outside the topic, right? If you've been preparing for entrance exam for more than a year, it becomes extremely depressive. And I do feel for you, because unfortunately we've been forced to memorize unwanted things. We've been forced to go into the textbook and learn from the textbook only. Medicine is learnt from surroundings. Medicine is learned from life. Take your mind out of the textbook. Look in the surroundings. You'll learn lots of them. Your Lysol, your Dettol has hypochlorous acid. If you've done your internship, if a blood spills, the first thing I do is I pour hypochlorous acid and close the place, because hypochlorous acid will destroy each and every bacteria. If I can make it perfect, it will destroy 99% of the bacteria, like the Dettol advertisement. I'm going to learn from the surroundings. I don't want an MCQ book to tell me that's most effective bactericidal. I already know that. You already know that, right? So come out of it. Only when you come out of the exam, come out of the textbook, you will appreciate medicine. That's what my body also does. It can produce hypochlorous iod and destroy it, right? Okay. Now, this is a normal mechanism of killing, and once HOCl is there, whatever bacteria it is, it will be destroyed. So for us, disease is more important. If NADPH oxidase is absent, I just want you to answer the leading question. If NADPH oxidase is absent, will acute inflammation happen? Not happen? Just answer yes or no. That's enough for me, because I want to arrive to the disorder. If NADPH oxidase is not there, will acute inflammation be successful or not? Not successful, right? So everything will become chronic, right? In mutation, it becomes chronic inflammation if it's absent. If you remember chronic inflammation, one of the classical chronic inflammation is tuberculosis, right? What do you see in the microscopy of tuberculosis? The microscope you see granulomas. That's a second name for me. Chronic granulomatous disease. It's a very simple way to remember it, right? My NADPH oxidase is absent, so acute inflammation cannot happen. It becomes a chronic inflammation, and every chronic inflammation might have granuloma, so I'm going to name it as chronic granulomatous disease. That's an MCQ for you. That's an NADPH oxidase defect, fine? If my MPO is defect, right? If MPO is defect, it's a simple term. It's a simple MPO deficiency. There are multiple ways to diagnose these. Multiple ways to diagnose this. I'm going to tell you the investigation of choice, because I just want you to remember investigation of choice, nothing else. Both of these are enzymes. Tell me the best way to assay enzymes. Both are enzyme defect, right? Can I say AST, ALT is also enzyme? They're also enzymes, right? They're also enzymes. Your creatine kinase, CKMB, all are enzymes, right? The best phase, enzyme analysis. For any enzyme defect, keep it in mind. Be it Gaucher's, be it G6PD, be it NADPH oxidase, be it MPO. The investigation of choices, enzyme analysis. Take a sample of blood, give it to the lab. The lab will tell you whether it's present or absent. That's as simple as that. You will read multiple name tests, not useful. Read the thing which is useful. It's a simple enzyme analysis which is going to help me to diagnose, right? Okay. So all this killing, all the respiratory burst happens in a place called phagolysosome. Okay. I'm sure you know what's a phagolysosome. Phagosome is the eating of the bacteria. Lysosome is where all these enzymes are present, right? So for me, normally phagosome and my lysosome are different. Let's assume this phagosome, this lysosome, they are different, unique. Then they will merge. Okay? Once they merge, I'll have your phagolysosome complex, right? It's going to merge, it'll form a phagolysosome complex. For this merging, I need a gene protein called as LYST gene. If it doesn't merge, will inflammation be successful? Will killing be successful? It will not be, right? So this defect, LYST gene defect, results in a condition called as Chidiac-Higashi syndrome. Okay, it results in Chidiac-Higashi syndrome. That's also a classical disease, right? Perfect. So we know all the inflammatory disorders. Inflammation is a very important topic. I want you to remember it, fine? Yes, Parival. Second year we'll have live batches. We'll teach you right from the word pathology till you are able to ace the exam, right? Okay. I'm just going to this table. We had LAD1, LAD2, we had chronic granulomatous disease, we had MPO deficiency, and we had your Chiari-Hashimoto syndrome, right? All these are disorders of inflammation, fine. So we saw about what is inflammation, how it's going to go, select in addition, everything. We saw the video as well, right? And we know the diseases also, right? Now let's go ahead. Again, it's a very simple question. Tell me what will be the right answer here. Comment. It's a very simple one, right? You must have read this in your even in 12th standard. Right? It's a very simple one. Kupffer cells. Okay. See, macrophages are something which is extremely important for us. Without macrophages, life would have been very difficult. And most of the diseases are also due to macrophages, right? Macrophages multiple names. In liver, like you guys said, it's classical Kupffer cells. What's the name of macrophage in spleen? I'll write the organ. You tell me what is the name of macrophage there. In spleen, what's the name of macrophage? In kidney, what's the name of macrophage? In CNS, which is the macrophage? In placenta, what's the name of macrophage? See, all these are macrophages only, but in different organ systems, I have different names, that's all. The name of macrophage in liver is your Kupffer cell. Name of macrophage in spleen, we call them an littoral cell. Again, they are also splenic sinusoid. These are the macrophages which eat your RBC, WBC, platelets, everything when they become old. Fine. Kidney, we have your mesangial cells, which are the macrophages. Right. CNS, we have a glial tissue called as microglia that acts as macrophage. We have astrocyte, oligodendrocyte, ependymal cells, and microglia. Right. Microglia is your CNS macrophage. In placenta, we have a cell called as Hofbauer cell. Consider yourself lucky. 5 years back, 10 years back, your seniors were memorizing the names of these cells. Hopefully in future, you will not be required to memorize. You'll be required to diagnose. If a question paper becomes clinically oriented, I want you guys to be happy because you're learning 4 years plus 1 year of internship to diagnose patients and treat patients. The same thing happens in MCQ. The exam should be easy, should not be difficult. If someone says it's a clinical based exam, it's going to be very difficult. They are just trying to make you get scared. That's all. Clinical scenario based questions are always easy. One liners are always difficult, right? Take it from me, because when you have a 5-line question, I'll have more and more clues. I can easily diagnose them. Be either strong in clinical medicine or surgical or pathology, you can diagnose every question. Any one of them, that's more than enough, right? Okay. Next, I'm going to talk about hypersensitivity. Generally, I don't talk about hypersensitivity. I'll leave it to your microbiologists because definitely they are far better than me in hypersensitivity. But I'll just give you a gist of hypersensitivity because I want you guys to. There is a misconception regarding few diseases, what type of hypersensitivity they'll fall into, with a type 2 or a type 4. We'll just clear that out, right? Hypersensitivity reaction. We have 4 different types of hypersensitivity reaction. The type 5 was there before you were born, so I'm not going to talk about that. There are only 4 hypersensitivity reactions for us. That's more than enough for us, right? The type 1 hypersensitivity reaction is allergic mediated. So anything related to allergy will result in type 1 hypersensitivity reaction, be it your anaphylaxis, be it your bronchial asthma, be it any food allergies. All of them are due to type 1 hypersensitivity reactions. Tell me which is the inflammatory cell of origin. Which is the inflammatory cell which is going to result in type 1 hypersensitivity reaction. Very simple. Almost every allergic response will be mediated by eosinophils. I'm not saying only eosinophils, predominantly eosinophils, that's all. And if I want to go with immunoglobulin, IgE is the classical immunoglobulin for allergic reaction. Every allergy will be resulting in type 1 hypersensitivity only, be it food, be it an environment by inhalation, hay fever, rhinitis, sinusitis, everything is type 1. Anaphylaxis, which is like the most worst case of type 1, that also is type 1, except one hypersensitivity. What is that? Remember this because again, like I said, there are few places where you can miss, and those places are the one which comes in MCQs. Contact dermatitis. What type of hypersensitivity is contact dermatitis? Type 1, type 2, type 3, or type 4? Because you might make a mistake here. Contact dermatitis. 1, 2, 3, or 4. Perfect. It is type 4 hypersensitivity. Because what happens is Whenever I think of dermatitis, the first cause which comes to my mind is urticaria allergic dermatitis. Urticaria is type 1 hypersensitivity, but contact dermatitis is type 4 hypersensitivity, not a type 1 hypersensitivity. Remember that, fine? It's type 4. Put a big mark if you're writing down. Please remember it's type 4 hypersensitivity, fine? Next form is type 2 hypersensitivity. Type 2 hypersensitivity is antigen antibody binding, right? It's autoantibodies, in other words, right? They are nothing but an autoantibody formation. There are different types of autoantibody formation, right? I'll give you a few examples. I'm sure you must have read them as well. There's a possibility the antibody can trigger my complement and result in phagocytosis, or antibody can trigger degranulation, or the antibody can destroy substances. Right? It can be in circulation, it can get attached to a cell, or it can get attached to a receptor. There are different types of antibody reaction, right? Like I said, anything in circulation, the circulatory cells, they can bind to an antibody. All of them will be type 2 hypersensitivity only. When I say circulatory cells, which includes your autoimmune hemolytic anemia, type 2, platelet destruction, you have ITP, which is type 2, kind of autoimmune hemolytic anemia, but due to Rh incompatibility, your erythroblastosis fetalis, that also is type 2. Okay? All these are in circulation. Anything in the cells, if it's there in the circulation, they're going to end up in type 2 only. Anything, I can call it an autoimmune thrombocytopenia instead of ITP. Again, type 2 only, fine? Again, there's a possibility that the antibody can be there on a surface, like skin. If you have a surface and the antibody binds to that, pemphigus, pemphigoid, they're autoimmune reaction, right? Again, they're type 2 hypersensitivity. I can have sometimes these autoimmune antibodies in your kidney, Goodpasture syndrome, type 2. That's again, it's a surface, right? It's a surface. It binds, it destroys them, right? Sometimes they can be in your neuromuscular junction, myasthenia gravis. Again, type 2. It's an antibody going and binding there, destroying there. Graves' disease. That also can be type 2, right? All of them are type 2 hypersensitivity. Okay. Type 2 is very, very important. There are few things which might look like type 2, but it's not type 2. I'll come to that soon, right? Type 2, anything in circulation, remember type 2, and I'm having a surface on which antibody is coming and binding, it's type 2 always, right? Next is type 3. Type 3 is your classical SLE, right? I love SLE. Very soon, in 5 minutes, we'll learn the reason why you have your malar and discordage, because SLE is beautiful. Type 3 hypersensitivity, SLE is about circulating immune complex. It's not antibody binding here, it's a circulating immune complex, right? Look, I think this is not the right place for you. We'll meet once you become a doctor, fine? I think it's much more important for you to go back to your textbooks, excel biology, physics, and chemistry, and come back soon, right? So when you have a circulating immune complex, see, I'm having a blood vessel. In this blood vessel, I'm having an antibody with an antigen. That's my immune complex, right? So if circulating immune complex is the reason for type 3 hypersensitivity, can I say this will be vasculitis? Only vasculitis, right? Because if this circulating immune complex deposits, it can deposit on the vessel wall. So it has to be a vasculitis, right? So the circulating immune complex is going to result in vasculitis. Remember that type 3 is kind of attached to vasculitis only. PSGL. I'm not primarily calling that in vasculitis, but yes, glomerulonephritis. Vessels are involved. Type 3 hypersensitivity. SLE. SLE is nothing but vasculitis. Lupus nephritis. Vasculitis. Third, polyarteritis nodosa and vasculitis, right? Simple. All something related to vessel, because they have to deposit there only. And just one more. It's something involving the vessel. So it has to get deposited in the vessel wall for me to have a reaction. The deposition will be more when there's a filtration. That's why kidney is more commonly affected, right? Filtration. Just arthritis, reactive arthritis, not rheumatoid, reactive arthritis. What happens here is I'm having circulating immune complex of bacteria, but it's getting filtered in the joints because the synovial fluid is nothing but formed by filtration. At filtration force, attracts the immune complex, gets deposited and having reaction, right? Here, it's a filtration force. See, the reason why I'm going in depth and teaching you is you might not forget them, that's all. It's vasculitis or a force should be there for a type 3 hypersensitivity reaction to happen, right? Type 4 is the best part. Anything involving lymphocytes go with type 4, be it CD4 positive or CD8 positive, it's type 4 only, fine. Type 4 is actually a tricky thing. When I tell you rheumatoid arthritis, what antibody comes to your mind? I want you guys to comment about this. Rheumatoid arthritis, what antibody comes to your mind? Rheumatoid arthritis, what antibody comes to your mind? I'm sure for quite a few of you, your rheumatoid factor and citrullinate peptides, those do come to your mind, right? If it's type 1 diabetes, what antibody comes to your mind? GAD antibodies comes to your mind for sure, right? There are quite a few places where type 4 and type 2 will have an overlap. Pernicious anemia, you'll have antibodies to your parietal cells that do come to your mind. The receptor, these do come to your mind, right? So there's an overlap between type 4 and type 2. Your Hashimoto's thyroiditis, antibodies to the thyroid peroxidase do comes to your mind, right? What happens in type 4 is there's slight overlap. What happens here is there is an insult. So let's say, for example, let's take thyroid. Some virus destroyed the thyroid. This resulted in increase in T cells. That again destroy the thyroid because virus can definitely increase my T cells, right? That destroy my thyroid. When thyroid is destroyed, the destroyed thyroid produces new antigen. Okay, the destroyed thyroid produces new antigen. This new antigen will trigger antibody against TPO. See, this is a basic pathogenesis of Hashimoto's thyroiditis. I'll repeat it once again. I'm having a virus. I'm just giving a history of viral infection. That viral infection, the T cells destroy my thyroid. The thyroid breaks. Let's assume this is a normal thyroid. It breaks. When it breaks, my immune system will consider the broken thyroid as a new antigen, creates an antibody to thyroid peroxidase. That will further definitely cause hypothyroidism only, right? This is the pathogenesis of Hashimoto. If this is right, the pathogenesis is mediated by T cells or it's mediated by antibodies. Who's the reason for it? T cells or antibodies? It's very important. If you understand that, you will not have a doubt at all. It is mediated by T cells. So if it's mediated by T cells, the hypersensitivity is type 2 or type 4. Whenever it's getting involved, it is type 4 hypersensitivity, right? So type 4 hypersensitivity, I want you to remember this pathogenic model because if you remember this, you won't make a mistake. Rheumatoid arthritis. Though I have rheumatoid factor or an CCP antibody, it is type 4, not type 2. Type 1 diabetes. Though I am having anti-GAD antibodies, it is not type 4, not type 2, it is type 4. It's always type 4. Hashimoto's. Though I am having antibodies to thyroid peroxidase, it is type 4, not type 2. Pernicious anemia. Though I am having antibodies to your your parietal cells, type 4, not type 2. But I'm just going to leave it to you. If there's a question which says rheumatoid arthritis, type 4, type 2, both of the above, what will you choose? Susanna, I'm not able to understand why iron deficiency came here. Can you explain why? Megaloblastic anemia, right? Pernicious anemia will cause megaloblastic anemia, not iron deficiency, right? If it's both the options, go for both the options. I would put it like this, type 4. If both, I would prefer both. Last, I would prefer only type 2. Okay. Again, the MCQ is always based on the options because I will teach one thing. The options, if they are different, the entire answer changes, right? Type 4 for all of them. In addition to this, there are classical type 4 hypersensitivity like your contact dermatitis. I'm not going to talk about that. You guys know that, right? TB, your contact dermatitis. All the classical type 4 hypersensitivity. And one more person. There are few things which are mediated by Th17 cells. Okay, Whenever Th17 comes into picture, it causes increase in both neutrophils plus lymphocytes. This also is type 4 only, which means acute on chronic inflammation. There are two classical disease where you must have read this for sure. I'll tell you one thing, you're going to tell me the answer. In which condition do you see Monroe's microabscess? Monroe's microabscess. Which condition do you see Monroe's microabscess? You see them in psoriasis, right? Psoriasis or psoriasis. Psoriasis is acute or chronic? It's undoubtedly chronic. Abscess, acute or chronic? Abscess neutrophils, right? Pus cells, it's acute. It's a chronic inflammation, lymphocytes, and also as acute, Th17 mediated, right? Psoriasis. Where have you heard about cryptapsis? Cryptapsis. IBDs, ulcerative colitis, Crohn's disease, right? Chronic or acute? Chronic disorder, but still there's abscess formation, there's neutrophils there, right? It's acute on chronic inflammation. Whenever I have acute on chronic inflammation, IBD, your ulcerative colitis, Crohn's disease, or psoriasis, I'll have acute on chronic inflammation because both of them have Th17 mediated. Whenever Th17 comes, that also is type 4 hypersensitivity, fine? Okay, just remember this part. Please don't get confused here. Though I have antibody as the modality for diagnosis, it's not type 2, it is type 4. Right? Great, super. So now we have an overall view of type 1, type 2, type 3, and type 4. Just to quickly recap, type 1 is allergic, type 2 is antibody, type 3 is vasculitis or whenever there's a filtration force, and type 4 is your T cell mediated. Fine. Thyroid peroxide is affected by iron deficiency anemia. Susanna, I'm really not able to find the link. Maybe we'll talk sometimes on the road. Fine. Antibodies to thyroid peroxidase will be there in case of your TPOs, right? Hashimoto's thyroiditis. Okay. Now, since we have a good amount of knowledge, you're going to answer. I want everyone listening to the lecture to answer. It's fine if you make a mistake, comment here. You're not going to lose anything by commenting here. I'm not going to give you ranks, right? I'm just going to teach you. So do comment the answer. Simple ones. Rh negative mother, Rh positive fetus. It's your erythroblastosis fetalis, a classical example of type 2. Whenever you read questions like this, reiterate, remember whatever I taught you. It's circulating cells. Okay, you have to come back to the concept. It's RBC, it's a circulating cell, has to be type 2 only. Circulating cell cannot be affected by any other hypersensitivity, only type 2. RBC, WBC, platelets, anything, fine? Perfect. A child got a honeybee sting. Next question. After the child presented with a hypotension, edema, breathlessness, which are the following antibodies responsible for that? And it's a simple one. You guys are going to jump to the answer. What type of hypersensitivity? It is type 1 hypersensitivity and it is classical IgE, right? Tell me what will be the answer here. If I have to tell, what will be the answer? If you have to choose between these two, which will perfectly fit in this clinical picture, allergy or anaphylaxis? It's IgE, perfect. It is allergy or anaphylaxis. It is classical anaphylaxis, right? Hypotension, edema, breathlessness, where is in hemodynamic compromise. Whenever there's a very severe hemodynamic compromise, I'm going to think of an anaphylaxis and not a simple allergic. Maybe sneezing, little bit of wheeze-like thing is okay, but it's going to be anaphylactic shock. Right? So can I say, even for an anaphylaxis to happen, there need not be a previous exposure. It's a first exposure and kicks it off, right? So this is very, very important. See, you guys are going to practice in future. You guys are not just going to write exams. You will pass the exams, and next exam you will clear the exam. We are going to learn more together soon. So if you're an intern or a post intern, I'm sure you must have given antibiotics. Am I right in saying that there's a chance that antibiotics can trigger anaphylactic shock? Though the percentage is very, very minimal, it can. So remember this, anything which you're going to put into the body, anything which is parenteral, always needs a test dose. But keep in mind that test dose also can trigger anaphylaxis. Bee sting. What bee sting will give milligrams. It's not going to give 5 liter of bee venom, right? Milligrams. Milligrams and micrograms are enough to trigger anaphylaxis. So if you're an intern or post-intern, please put test dose for every drug which goes inside your body. Lignocaine needs it. Axum needs it. Anything which is going to go parenteral should have a test dose. And even the test dose, after giving the test dose, wait for 5 minutes with the patient. Because if it's anaphylaxis, it doesn't happen after 5 to 10 minutes. It will be immediate. Allergy I can manage. It doesn't matter at all. But anaphylaxis, it's our job, so that we should make sure we lose no patients in future. Fine. Okay. So 2 things regarding hypersensitivity. Okay. Next. It's a very simple question. I'm not going to talk much about that. The picture speaks more than what I have to talk about, right? Answer. Shruti and Sridevi, penicillin we generally do, but even for taxin, cefotaxime, when you put inside your body, you have to do for that as well, right? The classical question, right? Congruent is enough for me to diagnose. Moreover, that I have a picture with a polarizing microscopy, the classical apple green birefringence. Diagnosis is simple, it's amyloid, right? Sometimes that's why I said, how many of you guys put up your hand or say yes? If there's an image based question, you're scared about the image, especially in pathology. There's an IBQ, you're scared about IBQ, yes or no? Or any subject. Unfortunately, the segment which I'm in is kind of making us robots, not letting me think at all. When there's an image based question, it should not be difficult. You have an extra clue, right? You have an image as an extra clue. When you have more clues, life should be easy. But I'm loading you saying that IBQ is difficult, scenario based question is difficult. No, I'm here to break the stigma. I'm here to make sure you understand your potential. That's enough. If you do that, sorted. You won't need me after 6 months. You'll never need me after 6 months, right? So whenever an image is there, ignore the image. Don't even look at the image. Even without looking at the image, most of the questions you can answer, right? Let's assume there's no image here. When a stain with Congo red visualized under polarizing microscopy, what will be the answer? No image. Congo red, it has to be amyloid. I don't want an image in this IBQ. Most of the IBQs don't require image except for few spotters. If you have a patient 10-year-old or 20-year-old cough with expectoration for the past 3 weeks, microscopy shows whatever it is. Diagnosis tuberculosis. Microscopy should show granuloma only. Be confident on that. Be confident on this part. Ignore this part. Use it for confirmation. Apple green birefringence. You feel good in the exam hall? Yes, I picked up the image, right? Generally for an IBQ, please don't look at the IBQ. Going forward, whatever question you solve, if it's IBQ, hide the image. If you can solve the question without the image, till this time you're making a mistake. In future also solve the question without the image, fine? Now we are going to look at a little bit about amyloid, right? I want a few things for you to remember in amyloid. Again, I'm going to simplify things so that you remember substances with 1 or 2 words, that's all. One word for pathogenesis. What are the types of amyloidosis? Amyloid is excess deposit of protein. Okay? Excess deposit of a proteinaceous material. It's protein only. So whenever anything gets deposited more, there are only 2 chances. There's going to be an excess production, or there will be a reduced destruction. It's not being removed properly. These are the only 2 reasons why amyloid is formed, right? In case of an inflammation, I'll have serum amyloid A protein which is secreted more, right? You have your multiple myeloma. In multiple myeloma, my light chains are produced more. It causes AL amyloidosis. In case of an inflammation, it's simple. Inflammation, there's something called serum amyloid A protein. We call them an AA amyloidosis. Chronic inflammation will definitely have amyloidosis. Simple, right? It's excess production, that's all. You have, let's say, your medullary carcinoma thyroid. Medullary carcinoma thyroid arises from parafollicular C cells of thyroid and they secrete calcitonin. I have something called calcitonin. Again, deposit amyloidosis, excess production. Give you 1 or 2 examples for reduced destruction. There's a protein called as A beta. Tell me which condition will have A beta amyloid? The protein called as A beta. That happens in CNS, Alzheimer's, right? So what happens in Alzheimer's is, for you and me, the beta protein, that's amyloid protein, which is there in the brain, will be destroyed. But in Alzheimer's patient, they are not getting destroyed. Right? They're not getting destroyed. That's amyloidosis. Shruti, I think you have confused A beta from A beta 2 microglobulin, right? Beta 2 microglobulin is dialysis related, right? Don't confuse that. Dialysis is your beta 2 microglobulin, and A beta is your senile amyloidosis seen in brain or your Alzheimer's disease, right? This is seen in chronic hemodialysis. The reason why beta 2 microglobulin is seen in chronic hemodialysis, it's an integral component of your MHC complex. Cells will not be removed by dialysis membrane, right? So they keep on remaining over the period of time. So you'll have beta 2 microglobulin, right? A beta for Alzheimer's, beta 2 microglobulin for your hemodialysis induced amyloid, right? So these are the classifications of amyloid. First thing I want to remember is excess protein deposition. That's all. The second thing, and the only thing which you want to remember, is amyloid always gets deposited around the vessels. It is enough for me to understand many things. Wherever you have the body, amyloid gets deposited around the vessels. If this is true, am I right in saying that kidney is one of the organs which will be commonly affected? Because can I say kidney has lots of vessels? They do, right? Lots of vessels. Entire kidney is made of glomerulus, tubules, capillaries, right? So here, renal amyloidosis is a very, very common thing. It's a most common subtype. It's definitely there. Someone said waxy kidney. Yeah, it's a protein. Protein will be waxy. If you have touched chicken wings, that's the nature. It's a waxy nature. Every proteinaceous thing is going to be waxy. Any muscle protein is waxy, right? Same way this also will look. It will not be friable. It will be waxy condition, right? So that's the most common thing. Not just that, I can have it deposited in liver. I can have it deposited in spleen. I can have it deposited in heart. Since I've told you the basic thing, you're going to tell me where it gets deposited, right? Let's go back subtly to your maybe anatomy and histology. In liver, there's a space which is seen around the sinusoid. What is space called as? We have space around the sinusoid. A classical space, what is it called? Perisinusoidal space of Deci. In liver, that accumulates in space of Deci. Okay. Next, spleen. Just a second. Hey, sorry guys, I'm back. Perfect. In spleen, it's again the surrounding the vessels, right? When you look at the spleen has two guys. That's not how a spleen looks. Okay, spleen has two places. It has my white pulp and it has red pulp, right? It has both white pulp and red pulp. So in red pulp also I can have deposit of amyloid. In white pulp also I can have deposit of amyloid. If it's in red pulp, it will get deposited like this because red pulp is very, very big area, right? In a white pulp, it will get deposited like this. Because white pulp are your periarteriolar lymphoid areas, right? It will get deposited like that, right? If it's getting deposited in red pulp, it looks like a lake. We call them an lardaceous spleen. If it gets deposited in a white pulp, we call it your sago spleen. Sago spleen is nothing but your white pulp deposition. Your lardaceous spleen is nothing but your red pulp deposition, fine? So we know both red pulp, we know both white pulp, and we know both spleen. Heart is considered your biggest vessel, right? In heart, I'll have your subendocardial deposit below my endocardium, right? Now I have all these things, right? When my amyloid gets deposited in the subendocardial region of the heart, what happens over the period of time is my conduction system will be abnormal. It's protein deposit, extracellular. Heart will not be able to pump properly. You can have restrictive cardiomyopathy, you can have arrhythmias. Because heart is not going to pump properly when it is there, right? I have all these organs. Tell me which is more dangerous. You're going to determine everything. I'm not going to talk about everything. Tell me which is more dangerous. Which will kill the patient? Renal, liver, spleen, heart. It's not rocket science, right? You guys know that. See, that's what MCQ comes. You already know them. You're not able to apply the logic fastly in the exam, right? Simple. Cardiac amyloidosis is more dangerous. It's lethal. As of now, we don't have any treatment for cardiac amyloidosis. Hopefully in future, there are few drugs in pipeline. Hopefully in future, we'll know about them, fine? Cardiac amyloidosis is lethal. Renal amyloidosis is common. My reason why renal amyloidosis is not lethal is, let's assume kidney fails. Can I replace the kidney? Or can I make the patient live with dialysis for the next 5-10 years? Easily possible, right? But I cannot replace heart so easily, right? That's why cardiac amyloidosis is lethal, and renal amyloidosis, though being common, is not that lethal, fine? It's dangerous, not that lethal, fine? Okay. So that's about amyloidosis, fine? And always amyloid in microscopy, it's surrounding the vessel. It will be pink in color on light microscopy on a HNE. So what we do is, we do Congo red stain because there are many things which are pink in color. Whenever there's a Congo red stain in question, please look at what the question is asking. After Congo red, if you're going to do light microscopy, the color will be salmon pink color. It'll still be pink in color only. After your Congo red stain, if you're going to do a polarized microscopy, it will have your apple green birefringence, right? It's based on what is happening, your Congo red or your polarized microscopy, light microscopy or polarized microscopy, fine? That's in just about amyloidosis. Amyloidosis has been a question has been asked both be it FMGE exam or NEET PG or INICET. At least once every couple of years it comes, fine? It's not a very repeatedly asked topic, but why I'm concentrating on this is it's easy to score. I cannot twist facts here. It's simple topic, and if you remember that, you'll definitely might get 1 or 2 MCQs, fine? Next question, tell me the answer. 56-year-old diabetic patient, chronic renal failure, undergoing hemodialysis. Which of the following amyloid is most likely to get deposited? Ideally, it should have been beta 2 microglobin, right? Beta 2 microglobin, not the A beta guy, not the AA amyloidosis, or not ACAL, right? It's beta 2 microglobin. This is seen in Alzheimer's, this is seen in inflammation, this is seen in your medullary custom of thyroid, right? Great. Perfect. Right. Next. Just few MCQs regarding neoplasia, because I have discussed neoplasia in detail in the first sprint as well, and we'll learn more things in future also, fine? Which of the following arises from all 3 germ layers? These are feel good MCQs. You will definitely know the answer, and answering them makes you feel happy, right? All 3 germ layers you must have read in your second year itself. It's one of them is classical teratomas, right? I'm not going to talk about teratoma here, but I'm going to talk about neoplasms of testis, right? Teratoma can happen in testis as well as in ovary. Okay, I'm just going to give you a practical problem. You're going to tell me how to solve it. Let's assume it's a 30-year-old person came with a testicular enlargement. Okay, this is what the person comes to you. 30-year-old person with testicular enlargement. You're the doctor. You're seeing the patient, and you have to say, okay, let's see what to do. Can you do an FNAC or a biopsy of testis? Yes or no? I want you guys to answer whatever I'm asking in the next couple of minutes, because it's very important for us to understand. Can I do an FNAC or biopsy? You can't do an FNAC or biopsy, right? It's not possible, right? Yes, Wasim. Wasim Akram talking about Yuvraj Singh. That's a good one, right? You can't. Why you can't do an investigation? Why no FNAC or biopsy? Tell me the answer. I know that you can't do it, but why no FNAC or biopsy? Answer and excellence always lies in why, not knowing the fact. Google will tell more facts than any one of us here within a fraction of a second. Why? I'm sure you must have known the answer also for why. we'll say that there'll be a needle tract spread, right? There'll be needle tract spread. That's the reason you don't do an FNAC or a biopsy. Quite a few of you would have known this, right? So my thing is, whenever again a fact is put to you, try to question back the fact, whoever it is, me or any teacher in the world. Only when you question back, you will keep on improving your knowledge. This is right. But if this is true, let's say I'm having a thyroid tumor. When I do an FNAC, won't it spread via the needle tract in thyroid? Yes or no? Yes. Breast cancer, I'm doing a biopsy. Will the tumor spread via the needle tract? Yes or no? Yes. Any cancer, when I'm doing a biopsy, there will be needle tract. Will it spread or not? It will spread. Yes. So am I right in saying that for no tissue I should do biopsy? But we do biopsy, right? Then why testis is unique? You should know the answer till the bottom of whatever is required, right? Needle tract spread is true. But for me, the problem here is testis is an abdominal organ. It's not an organ in the scrotum, it derives from the abdomen, right? But when you do let's say there's a testicular tumor, I'm doing an FNAC. FNAC will cause the tumor to go to the scrotum. When it goes to scrotal layers, it goes to inguinal nodes. So what I'm doing here is, normally if it's a testicular cancer also, it goes to para-aortic pre-aortic lymph nodes. It will not go to your inguinal lymph nodes. But via inducing a needle, I'm taking the tissue and changing the direction of spread. That is the reason I should not do an FNAC or a biopsy in testis. Please be very, very careful. Remember this, right? It's not just this, it's the lymphatic drainage. When you do a thyroid FNAC also, it will spread to cervical. When you do a breast cancer biopsy also, it will spread to axillary for sure. But breast also drains here. The tissue also drains here. So it's okay for me. But here, I separate the direction of spread. That's why I don't do a testicular FNAC or a testicular biopsy, right? Let's come back to original question. It's a 30-year-old testicular enlargement. How do you diagnose them? Can you straight away go and do a surgery? So our problem is I cannot have a FNAC or I cannot have a biopsy. Can I do a surgery straight away? Yes, no. No, right? You can't say that just because a patient has an enlarged testis, I'm going to cut it and throw away. There are quite a few guys here. It does pain, right? It's difficult. It's difficult to take a decision. That too, for a young person, it's a life-changing decision, right? So how do I investigate this? There are two modalities of investigation. One is ultrasonogram. The other guy is tumor marker. For testicular tumors, the way is going to be ultrasonogram and tumor markers. Ultrasonogram will show there's a capsulated lesion, most likely tumor. Tumor markers, alpha fetoprotein elevated, non-seminomatous tumor. LDH is more, very huge tumor, right? So these are the guys which are going to help me. Beta HCG more might be a choriocarcinoma, fine? Hi Atmiadak, hope you are enjoying your post-NEET phase. Okay, right? So it's ultrasonogram and tumor marker, then go ahead with the surgery, fine? Okay, so it's not related to testicular tumor. I just want to take a detour and go to that. Okay. Now, it's an image-based question. With this image-based question, you cannot hide the image and answer the question because the entire question here is based on the image. Tell me whatever you think is right, A, B, C, and D. You still have 25% right option, even if you close your eyes and type something. Let's see how your lady luck works. Close your eyes, type A, B, C, or D. Retinoblastoma, medulloblastoma, Ewing's, or neuroblastoma. It's a clear-cut case of one retinoblastoma. This is a rosette, right? I'm going to talk about rosettes very soon, and we'll see how we can identify the rosettes soon, right? There are 4 different types of rosettes, and all the 4 rosettes can be easily identified. First, in rosette, I have something called a true rosette and something called a pseudo rosette. A true rosette has a lumen in the center. If lumen is present, it's a true rosette. If you don't see a lumen, it's a pseudo rosette. That's all. That's a basic difference here, right? It's a very basic difference here. So let's say I have first rosette like this. I'm having cells in the form of a circle, and I'm having a pink center. That's my first rosette. Second rosette, I'm having a center lumen. I'm having cells surrounding that, and I'm having a pink color surrounding, right? There's a lumen, pink layer, and cells surrounding that. The third rosette is just like this. I'm having lumen and I'm having cells here. Okay. The fourth is actually called as a pseudo rosette. You have a blood vessel. Surrounding the blood vessel, I'm having tumor cells. Okay. These are the things. So now of these four, tell me which are true rosettes. The fourth one, like I said, it's named as pseudo rosette, right? These two are actually true rosettes because only 2 and 3 has a central empty space or a lumen in the center, right? The first guy, like Love for Anatomy said, it's a neuropil. It's called as an Homer right rosette. It's neuropil. This pink color is called as a neuropil. So it's seen in condition where I'm going to have the neural tissue, neuroblastoma, medulloblastoma. Medulloblastoma happens in CNS, right? You see them in neuroblastoma and medulloblastoma. Okay. Next, this central lumen, pink surrounding, then cells, we call them Flexner-Winter-Steiner rosettes. The Flexner-Winter-Steiner rosettes are seen in retinoblastomas. Okay. We'll look at all of them, then we'll go to the microscopic finding. We'll see what it is exactly. Fine. This is a classical rosettes. Fine. Okay. That's your true ependymal rosettes. Classical true ependymal rosettes. It's seen in ependymoma. That's all. Fine. I just come back soon to medical college. We'll learn more together. Last I said it's in perivascular pseudorosettes. So perivascular pseudorosettes is very non-specific. I can see them in medulloblastoma. I can see them in Ewing sarcoma. You can see them in your neuroblastomas. You can also see them in ependymomas. It's a very non-specific one. It's not diagnostic at all, but the first three can come in an exam, and it has come quite a few times in microscopy also, so you should know how the rosettes look. Rosette is a circle of cells arranged in the form of a circle. That's why I call it rosette. And I have different shapes available here. Fine. Now let's go to the image and see what type of rosette this is. Central lumen present in 2, lumen absent in 1. Fine. I'll just zoom this here. Maybe you look at this part. I'll concentrate on this one, though others are also classical, but this looks much more clear. Can I say here, this thing, does it have a central lumen? Yes or no? I'm sure you guys can type Y or N. There's a central lumen here, yes or no? It is present, right? True rosette, pseudo rosette. It's a true rosette, right? Beyond the central lumen, maybe I'll put a dot here. That's a central lumen for me. Is there a pink space? There's a pink layer, right? I'm sure you can appreciate this pink layer outside the central lumen. I'm having a central lumen. I'm having a pink layer. Surrounding that, I'm having cells. What type of rosette is this? The classical Flexner-Winter-Steiner rosettes, right? Having a lumen, having a pink area, and I'm having cells. That's how we drew our Flexner-Winter-Steiner rosettes, right? And Flexner-Winter-Steiner rosettes is seen in your retinoblastomas, fine. It's a classical finding seen in retinoblastomas, fine. Okay, great. Next. It's a very simple diagnostic point. Like I'm sure most of you guys will know the answer. Like I said, the only purpose of this question is to make sure understand why I have these findings. Answering questions why will open up to many more MCQs in future. Young lady, photosensitive rash, arthritis, and presence of anti-Smith antibodies. That's one of the classical antibodies seen. Simple, right? It's your SLE. Anti-Smith as well as antibodies to double-stranded DNA. Classical diagnostic points or very specific antigens for SLE, right? We have specific antibodies for SLE. Which is a sensitive antibody? Sensitive to ANA. Anti-nuclear antibodies is a sensitive antibody, and SLE is a specific antibody, right? Perfect. Okay. Now, I'm going to ask you a simple question. Just now we saw What type of hypersensitivity is SLE? Type 1, 2, 3, or 4? Classical, type 3 hypersensitivity, right? Which means I'm going to have a circulating immune complex. The immune complex are going to be there in the circulation. When I have a circulating immune complex, my only question is, why do I have malar and discoid rash? Why do I have rashes in the skin? The reason for rash in skin is, like I said already, I'm going to have immune complex in the circulation. When it's in circulation, it will not have any problem at all. Only when the immune complex gets deposited in the vessel wall, right? It gets deposited here. I'm going to have a reaction. You'll end up in vasculitis, right? So which means I need to know when it will get deposited, right? It's type 3. I know when it gets deposited. Can I say if a vessel is like this, like curved vessel, right? I'm having an extremely curved vessel or an hairpin shaped bent vessel, right? If you have a vessel like that, is that possible during the curvature, the velocity or the speed of the blood will become less and it can get deposited? It can, right? So here it can get deposited because it's a hairpin shaped curve. If you've driven a vehicle in a hairpin shaped bend, it will slow down. The same happens for everything. Once it slows down, it gets deposited. This deposit will trigger antigen antibody reaction and will cause vasculitis. So which means whichever part of the body has bent vasculature will result in SLE. That's all. That's a simple concept of SLE. It's the hemodynamic alteration. Now let's look at skin. The reason for skin is, you must have definitely learned this in dermatology, right? We have epidermis, dermis. In dermis, we have papillary dermis, reticular dermis. In which of these you'll have vessels? In epidermis or papillary dermis or reticular dermis? You'll have vessels in reticular dermis. Sorry, in papillary dermis, right? How are they? They are hairpin shaped vessels. The papillary dermis vessels are actually hairpin shaped. That's why SLE has lots of photosensitive reactions. It's because of the shape, it's because of the hemodynamics. So why malar discoid rash? Malar discoid rash for the simple reason it is exposed to sun. When it gets exposed to sun, I'll have vasodilatation. Vasodilatation causes more turbulence, causes more deposit. If you have read dermatology, the SLE rash, it has a very classical description. It will be written that it's malar discoid rash involving the malar area, not involving the nasolabial fold, right? Which I've heard for sure. Also is very, very classical because here the cheek, how much ever thin you are, the cheek will have good amount of fat, and anywhere wherever there's an adipose tissue is extremely rich in capillaries. There are more vessels here. That's why it gets affected. Nasolabial fold doesn't have much of fat, doesn't get affected much. It's a very classical thing. If this is true, let's link pathology. Let's link one to other so that our concepts are very rock solid. Rich in capillaries. Just now we read a disease where a deposit is seen surrounding the blood vessel. What disease was that? We read a disease just now, a disease which has deposits surrounding the blood vessel. Which disease? You know the answer. Just now we saw the pink one, the Congo red and everything. Amyloidosis, right? So can I say, if it gets deposited surrounded the blood vessels, the best tissue for me to analyze is fat, because fat has abundant blood vessels. So it's just a fact. I'm going to link it with the concept. That's why in amyloidosis, the best test to diagnose amyloidosis, abdomen fat pad aspirate, because fat has more capillaries and amyloid gets deposited surrounding the fat, right? Same fat rich in capillaries. This malar area has fat and has skin, so I'm going to have malar and discoid rash, right? There's a basic reason behind malar and discoid rash of SLE. If you know this, when you go to MD medicine or your nephrology, the same concept you can apply. You'll definitely be able to understand everything about SLE. Hi Tejas. Okay, that's one. Next question. I'm sure you guys know the answer. This also, I'm discussing about the PYQs, right? You guys are experts in PYQs. Comment on the answer. I'll mute myself for a few seconds. Okay. Dye industry. That's one of the classical clues here. And the patient presents frequency of hematuria, urine frequency, and urgency, right? So indirectly, I'm saying that aniline dyes exposure, any dye exposure will result in bladder cancer. And the commonest bladder cancer here has to be an transitional cell carcinoma. It's a commonest bladder cancer for sure, right? Like I said, PYQs, you are very strong about it, right? Okay. If you remember a couple of years back in NEET PG, in the exam, I think last year, the question came that there's a doubt between benzene and benzidine. There's a huge havoc in the recall session. Benzene versus benzidine. Because benzidine is a dye. Benzidine causes your bladder cancer. Benzene causes leukemias. Okay? So don't read based on fact. You can easily forget this, right? But here, look at the patient. Is there a possibility a patient with hematuria, urine frequency, and urgency will have leukemia? That's not the way of presentation, right? That question had some child with history of fatigue and ecchymosis and petechiae, cytopenias. That has to be leukemia. So go with the history, don't go with fact. If you read with facts, there's a possibility you might miss. Benzene is leukemias. Benzene is same like aniline dyes causes bladder cancer, right? Okay, it's a simple question on your carcinogens. Carcinogens is a very favorite topic for FMGs. Past 2 years, there are 2-3 questions which came on carcinogenesis, right? This one. This again is a question on carcinogenesis. Tell your answer. Though it's a little bit of an extrapolation, but still, you need to know the fact. It's a question on hepatic carcinoma or HCC. Which of the following is going to result in hepatic carcinoma? Simple, it's your aflatoxins, right? Aflatoxins can be easily be seen on peanuts. The peanuts has little bit of moisture, so your fungus can grow and the fungus can secrete them, right? Which fungus? Your Aspergillus species can grow on the surface of many grains, especially peanuts. Peanuts aflatoxin is so high. India is a major producer of peanuts, right? If you want to export peanuts, you have to test the aflatoxin levels, and only then you have to export it, right? That's how famous it is. Everyone in the medical curriculum knows about it. No, and everyone in the world who is in export business also knows that peanuts grains, which has a little bit of moisture content, the possibility of aspergillus to grow, and it can result in that. Fine, perfect. Wasim has given us one more thing: PVC and thorotrust. The polyvinyl chloride and thorotrust causes hepatic cancer, but it's resulted to hepatic angiosarcomas, right? Not a hepatocellular carcinoma. It causes hepatic angiosarcomas, right? You are right in calling it liver cancer, but a little bit a different variant of a liver cancer, right? Okay, great. Now we are done a little bit regarding your RBC disorder. Right? Now let's go to your general pathology. Now let's go to RBC disorders. See, general path is something which is more text heavy, more fact heavy. I have to remember it. RBC, WBC, systemic path are more logical approaches, right? If you can clear cut, understand the logic, understand the approach, you'll be definitely able to ace the exams, right? Look at an RBC. Any question regarding RBC, I want you to categorize them, classify them, and go and then write the diagnosis, right? Anything regarding RBC is going to end up in anemia. That's all. So history wise, I don't have any different opinion. Every anemia is going to present with fatigue, pallor. That's going to be the common denominator history wise or examination finding wise. A subtle more finding which will come too soon. Whenever you have a case of anemia, the first thing I want you to remember is see whether it's acquired or inherited. It is very important because even this year there's a question on spherocytes. There's a huge confusion whether it is spherocytosis or autoimmune hemolytic anemia, right? The first thing I want you to put a thing like whether it's acquired or inherited. The best way to know it's inherited or congenital is there'll be in family history. There's a family history, most likely I'm going to look at an inherited disorder, maybe an mutation related hemolytic anemia. Second, early onset. But again, put a star here. Not every inherited conditions have an early onset. ADPKD is an inherited condition, mutation, right? It's present at 45 years. But early onset can be there in some, might not be there in some, right? First, divide acquired inherited. Once you know that it's acquired inherited, the next classification, next division for me is in a simple division, hemolytic or nutritional. See, I want you to, whenever you read a question, these, draw a flowchart. Whenever you read a question, think about that. Hemolytic or nutritional. Once you know it's nutritional, I have only two things in nutritional. Life becomes very easy. Look at the MCV. That's enough for me. If it's microcytic, less than 80, call it IDA. If it's macrocytic, greater than 80, or if MCV is not given, you might have one more classical finding, your hypersegmented neutrophils. Okay, hypersegmented neutrophils, call it megaloblastic. These are classical findings. Apart from this, also I'll have multiple things, but these are very classical things. Okay, this is that. Fine. Let's go to hemolytic. In hemolytic, again, I have easy way to differentiate based on the history. I have two types of hemolysis. Can anyone tell me what are the ways or what are the places where hemolysis can happen? It can happen in two ways. One is inside the blood circulation, intravascular. The other one is extravascular hemolysis, right? Whenever it's hemolytic, again, try to delineate to some extent. Is it intravascular or extravascular? Because extravascular hemolysis has a classical examination finding, they might have splenomegaly. Splenomegaly can be an examination finding in extravascular hemolysis. Some of them are a combination of intra and extravascular hemolysis. That also might happen. But keep in mind, if it's pure extravascular, you will have splenomegaly, right? So that's my basic categorization of hemolytic. Again, I'll tell you pointers for every hemolytic anemia. Any hemolytic anemia which you're going to go forward, which you're going to diagnose, look at these pointers, which is very, very important. Take one by one. HS. HS should be adults. They are seen in adults, not seen in children. A very mild hemolytic anemia. They present with gallstones and they don't present with anemia. HS is extravascular hemolysis, so they'll have splenomegaly. That's a classical triad of hereditary spherocytosis. Very rarely it can present in children. Your question this year NEET exam. How many of you gave a NEET exam? If you're given that, it didn't have any of this. HS does not present with anemia. It presents with splenomegaly and it presents with gallstones, pigmented gallstones, because a very low grade hemolytic anemia. Fine. Okay. Since it's autosomal dominant inheritance, it presents in adults only. That's a triad for HS. Look at these pointers in your question to say it's HS. Right? And microscopy, obviously you see spherocytes. And investigation of choice for HS is EMA flow cytometry. At least remember flow cytometry, that's more than enough. Your osmotic fragility test has no role in diagnosis of HS. Just remember these things. These are trigger points. Any of them is there, go and diagnose HS. Right? Next, your G6PD deficiency. It's X-linked recessive, so male gender could be a clue, but again, it's a very, very vague clue. There will be a trigger. That's very, very important. Trigger-induced hemolysis. There's a drug intake, and then there is a hemolysis. There was your fever, malaria, then hemolysis, right? Trigger-induced hemolysis. But my problem with trigger-induced hemolysis, autoimmune hemolytic anemias also can have trigger. Until after trigger, what I'm going to do is microscopy. In microscopy, when you see this finding, bite cells, diagnosis of G6PD, or you have something called as Heinz bodies, diagnosis of G6PD deficiency. So the classical findings in G6PD deficiency, right? And investigation of choice, it's an enzyme. Just now we saw, right? Investigation is enzyme analysis, right? You're just going to diagnose the enzyme analysis. That's all, as simple as that, right? Just trigger points. The classical finding, look for them, then you will definitely be able to answer the question, right? Next, sickle cell anemia. The sickle cell anemia, most of the sickle cell anemia don't present with anemia. They present with your vasculitis, your vaso-occlusive crisis, right? Like dactylitis. One of the classical finding in sickle cell anemia is autosplenectomy. Look for this. Spleen is not seen at all. In imaging, there's no spleen. Autosplenectomy, sickle cell anemia only. The classical hint. Peripheral smear in microscopy, you will see your sickle cells. An investigation of choice for two diseases is the same. HPLC, which is better than your hemoglobin electrophoresis. Better than hemoglobin electrophoresis, right? I'll side by side write your TAL also. I'll write for TAL major because TAL minor is a very close DD for iron deficiency anemia. It presents like classical IDA. TAL major after 6 months, because TAL major will not present in first 6 months, because in first 6 months you will have fetal hemoglobin alpha 2 gamma 2. Beta thalassemia cannot manifest, right? So after 6 months, if you have any question saying transfusion dependent, there's almost like only one diagnosis. If you have transfusion dependency, it's going to be beta thalassemia major. Sickle cell anemia homozygous can also be transfusion dependent, but generally I'm going to think of TAL major, right? And prominent bones. The prominent bony arches in your face, your frontal bone, your zygoma, your jawbone, everything will be prominent. Classical chipmunk faces or hemolytic faces. Microscopy, your target cells. Though target cells can be seen in multiple conditions, one of the first thought is going to be thalassemia, right? Investigation of choice, same. HPLC versus hemoglobin and or hemoglobin electrophoresis. Obviously, the better one is HPLC, right? So you know how to differentiate them, right? Okay. Next, PNH. Only classical finding which I want to remember is early morning hematuria. The first voided urine is having hematuria. That's diagnostic of PNH. The second urine will be normal. Only the first urine will have hematuria, right? Next, PNH will have pancytopenia. That's also very, very important. With a cellular bone marrow. Remember this. This is the important finding. Pancytopenia with cellular bone marrow. Because most of the time, your pancytopenia will have hypoplastic bone marrow. The best example is aplastic anemia, right? If you have peripheral pancytopenia and you have a very good cellular bone marrow, think of PNH. That's one of the differential diagnoses, right? And investigation of choice is simple. Again, I'm going to use flow cytometry. Very classical finding, right? So that will help you to solve most of your hemolytic anemias. Okay. Yes, it'll have thrombosis also, like Wasim said. Thrombosis is generally the cause of death. So you can have, I'll add your point as well, Wasim. You can have history of Budd-Chiari syndrome. That's been asked quite a few times. Budd-Chiari syndrome and a hematological condition, thrombosis of your hepatic veins, think of again PNH, right? Great. So these are pointers, right? Look for these pointers. These are very, very useful. If you have a good handwriting, maybe write this down, take a printout and stick on your study table. Keep looking at them daily. So subconsciously, whenever you look at these pointers, you will automatically come to a diagnosis, right? So with these pointers and with basic information, we'll go and solve a few questions regarding RBC disorders. Okay. Diagnosis. You will jump into the answer. What's the answer? I want you guys to comment. Okay, great. It's a patient presenting with hemoglobin of 6 and the following nail change is seen. There's a classical nail change, right? That's your spoon-shaped nail. That's a koilonychia and that's your classical iron, right? Great. It's an iron deficiency anemia, classical iron deficiency anemia, right? It's koilonychia. I'll just tell you why there's a koilonychia. Because in reality, when you are going to become MD or MS, whatever it is, right? And whatever field you take, you will definitely see IDA. And you might see koilonychia very frequently as well. The reason for koilonychia is nail is nothing but keratin. So what happens in IDA is there'll be less amount of blood supply to the nail bed. Right? The nail bed will have less amount of blood supply. So what happens is this keratin becomes dry. It's not being produced properly. This will result in reduced production of keratin. Because I need good amount of keratin as a protein, right? If the protein is not perfect, it becomes a little bit destroyed. It kind of becomes like a boat. Normally nails will not be like this, but it kind of becomes like this, right? Because it's a protein, that's all. Like your hair, it's very dry hair. That's why you have proteins in shampoo that might not do anything, but whenever protein production is abnormal, it becomes dry. Whenever protein becomes dry, it kind of becomes like this. The best example to relate with real life is, have you seen the dried coconut leaves? You must have seen, right? This part, the stem part. When it's normal, it'll be good. If you have played cricket in your young days, have you played cricket with this bat? We used to have the coconut stem thing and we used to hit with it. It'll bend automatically. Any protein, when it becomes dry, when the protein content becomes less, it'll kind of bend, right? It's the same thing reason behind koilonychia, right? It's a bent protein. Now, with this concept, I just want you to honestly answer. Can I say whatever may be the cause of anemia, the blood supply to the nail bed will be less? Yes or no? Yeah, I want you to think beyond books. Hi Anmol, good evening. Because that's one thing which is going to make you grow beyond MCQs. Whatever may be the cause of anemia, the blood supply will be reduced, right? It will be reduced. So can I say, is there a slight possibility of koilonychia seen in, let's say, megaloblastic anemia? Possible? Or any anemia for that matter? Am I right in saying that I can see the same finding in any other anemia? Because the concept is this: very less blood supply, you can, right? Perfect. Then why do I read IDAs? I want you to make sure right from your undergraduate days, whatever anemia you see in real life, if you see 100 cases of anemia, 95 of them is going to be iron deficiency only. Rest entire RBCs for the 5%. Right? Since it's very common, very prevalent, I'm going to think of IDA first, right? It's a classical finding seen in IDA, but maybe in future you become a dermatologist, you will see DD for koilonychia also. You become an internal medicine person, you'll still see DD for koilonychia. You will have to unlearn. You read something in MBBS, when you go to MD, you will say, okay, it's not right. We'll unlearn and we'll relearn, right? As a classical finding koilonychia. Apart from this, you have one more condition. We have your Patterson-Brown-Kelly syndrome, right? You have your IDA with esophageal webs. Okay, that's all. That, though the association is very rare, might come in an exam. Fine. Next, anyone for this? It's a fact. Like I said, always facts are very difficult to remember. Supravital strain is done for. Supravital strain is done for. Reticulocytes, right? Perfect. I'll tell you what is a supravital stain and why it is required for reticulocytes. Okay. Before that, we have to learn a few things. The normal stain used in peripheral smear is Leishman stain, right? And when you take a biopsy, for a biopsy, we use a fixative called as formalin, right? We have formalin fixative. In Leishman stain, we have alcohol fixative. In Leishman, methanol is a fixative. What is the purpose of fixative? What does fixative do? Can anyone tell me the use of fixative? Fixative does not fix the cells to the slide. Fixative makes sure the cell doesn't die. Let's say I'm taking a patient's breast tissue for breast cancer diagnosis. Once you take it out of the body, the cell will die, right? If the cell dies and I'm not able to preserve it, in microscopy I will see necrosis or apoptosis. Those are the only two types of cell death. I cannot diagnose a cancer. So fixatives, the primary role is to preserve the tissue. it will preserve the tissue. Right? Supravital stains are the stains without fixative. Here it preserves, kind of freezes, so that I can use the slide even 10 years down the later, I can diagnose breast cancer, right? In a supravital stain, are the stains without fixative. Okay, they don't have the fixative, because what fixative does is it kind of destroys protein. If it destroys protein, reticulocytes will be destroyed, so I cannot count them, right? So supravital stain doesn't have fixative, and supravital stain can, they are live stains. The cells are still alive, their cells are still maturing, right? And one of the thing is new methylene blue, right? NMB for new methylene blue, or you have your brilliant crescel blue, crescel violet. Lots of them, all of them are supravital stain. They are all supravital, they don't have fixative at all, right? And they are used for reticulocyte staining, because when I use a fixative, it destroys protein, that's how it fixes cell. Here I can't use it because reticulocyte is nothing but RNA and the protein material only, fine. I cannot do that, so I use these things to do that, fine. The reason why I wanted you to know this is, let's say I'm taking a patient's blood today, I'm doing a supravital stain. Can I see the same slide after 10 days? Possible, not possible? Will the cell live or will the cell die? The cell will die, right? So for supravital stain or anything with reticulocytes, the report should be immediate. You take the blood, within 15 to 20 minutes, I have to give a report. Otherwise, I'm going to give a false report because it automatically will mature and some of them will die for sure, right? The concept of supravital is they don't have fixative, the cells are in a live state, and reticulocyte stain is stained by supravital stain, right? I wanted to introduce this because this is required for me. This is one stain for peripheral smear, Leishman. The other stain for peripheral smear is new methylene blue, fine? Great. Classical question. Maybe a classical image as well. Tell me your diagnosis. Keep quiet for some time. Okay, there's a classical one. It's a 24-year-old person with complaints of neurological defect. That's a clue for me. Reveals pallor and the image shows a classical finding. What does the image show? Like I said, whatever the clue points are here, that's a classical finding here. I do have one lobe, two lobe, 3, 4, 5, 6. It's more lobe, right? It's your hypersegmental neutrophil. I'll think of hypersegmentation when I have 5% neutrophil more than 5 lobes, or even one neutrophil more than or equal to 6 lobes. A single neutrophil has more than 6 lobes, I call it hypersegmented. And 5% of the neutrophil having 5 lobes also is enough for me to call it hypersegmented. Fine. Perfect. The clue here is neurological deficit. If I have to call between megaloblastic anemia, folate as well as B12 can both cause hypersegmented neutrophil, right? This is seen in both folate and B12. But in folate, you don't see neurological deficit. Only in B12, you see neurological deficit. Hence, option B is the right answer, right? Great. Since you guys picked it up and wrote the right answer, I'm going to add a little bit more information for us to make it better. Let's say I'm having patient 1. The patient has B12 deficiency. Okay. As a proven B12 deficiency, in serum B12 is low. And folate in this patient is normal. How do you treat the patient? Will you give only B12 or both B12 and folate? Only B12, both B12 and folate, only folate. Options. How do you treat the patient? This came in an exam. Not for an exam. Every practicing doctor, physician should know this. You should give only B12, never B12 and folate. See, there are few errors which happens and those errors should be rectified and should be changed. See, when I was doing my MBBS, the modality of it is give both. The treatment was that give both B12 and folate in any case of megaloblastic anemia so that it can tackle. Later on, they researched more and more and more, and they said that don't give both. You should treat only with B12. You have to relearn. If you learn the older way, ignore that. That's wrong. I'll tell you why it's wrong. Right? It's only B12 if it's B12 deficiency. If it's folate deficiency, only folate. That's all. What happens is if you use B12 and folate, okay, there'll be an abnormal redistribution towards hematolymphoid tissue. There'll be an abnormal B12 distribution to the bone marrow because both B12 and folate will take care of the bone marrow proliferation. So abnormally it will go to that, and there'll be an less B12 available for neurons or for myelination. So when you give both B12 and folate in a patient with only B12 deficiency, it results in worsening neurological defects. See, this was asked in AIMS exam. It doesn't mean that an FMG student should not know it, right? I don't care what exam you're going to write. You're going to become doctors, you're going to be future colleagues, that's all. And my goal is to make sure you understand the medicine and treat the medicine, diagnose it, and treat in the right way possible. If it's B12 deficiency, give only B12. That's the latest guidelines. And maybe in future, if it changes, we have to change automatically. That's why I said always be ready to unlearn and relearn. That's very, very important to ace medicine. Fine. Remember this. This came in an AIMS exam. Hopefully, in future, we won't do the mistake again. Right? It diagnosis. Simple thing again. Based on the peripheral smear finding, which are the following the most likely diagnosis? Can anyone tell me what is a smear showing? What is the smear showing? If I can draw the RBC separately, it looks like that. That's looking like an macrocyte, right? Teardrop cell, right? Okay, Wasim, you are right in calling it teardrop, but you went for option B, Al major. See, there's one more finding again. You have this target cell is also there. Like I said, target cell is important for me, but target cell has multiple differential diagnoses, and the image is marked teardrop cells, dacrocytes. So my entire focus is going to be on dacrocytes and not on target cells, right? We'll see why a dacrocyte comes. For that, we have to understand this is a bone marrow. Let's assume these are the bony trabeculae, and all the RBC, WBC production happens here. So for an RBC to come outside of the bone marrow, it's normally like this. It will squeeze and come outside. Because the gap is very small, it squeezes and comes outside. That's how normally it comes. Let's assume the bone marrow is becoming fibrotic. Okay. In other words, let's say normally you have a door, it's a narrow door, you squeeze and go outside. But now the door has lots of fibers through it, right? It's fibrotic bone marrow, which means it's like this. The only way to come outside is squeeze so much, right? So what happens is my RBC, for it to come outside, it has to squeeze so much and then come outside. Once it squeezes so much and comes outside, it becomes like a teardrop, right? So whenever there's a fibrotic bone marrow, the cell which comes outside becomes like a drop. It's very close, narrow orifice, right? That's the difference between normal bone marrow having an perfect biconcave cell and a myelofibrosis having your teardrop cell or your dacrocytes. Okay, it's a classical finding. I don't want you to forget it, right? It's a dacrocyte. Dacro means tear. Dacrocystor rhinitis. You must have heard about the nose and all those things. You will read that in ENT and ophthalmology, right? The teardrop cells, dacrocytes, seen in your myelofibrosis, not in TAL, not in myelodysplastic syndrome. Fine. Okay, great. If the arrow mark has been to target cells, then I would have thought of your thalassemia. Okay, great. Diagnosis. There's no arrow mark, but there's a classical history. Like I said, we are going to hide the image here. I want you to diagnose without an image. I don't know how to hide the image, but still, don't look at the image. Just look at the question and try to solve the answer. Let's see if that's right. If it's right, we'll do the same thing going forward. That's all. 3-year-old child with progressive anemia. Examination shows hepatosplenomegaly, right? And prominent malar eminence was a most likely diagnosis. Great, right? I said, even without looking at the image, she's a 3-year-old guy with progressive anemia. Unlikely to be these three options, right? Though I don't have any other finding, even if my peripheral smear is not there, 3-year-old hepatosplenomegaly with malar prominence, which means my bone marrow is having huge amount of hyperplasia. That happened only in a severe hemolytic anemia, and only severe hemolytic anemia, to be exact, it has to be a TAL major, right? The beta thalassemia major, that's enough for me. I need not have a microscopy at all. If I want to look at the microscopy, like some of you guys said, you can see a classical target cell. Looking at target, right? All these target cells are diagnostic of obviously thalassemia major, right? History is more important. I don't want an image in any of the MCQs. Please don't look at the image, right? More than enough for me is the history, right? Classical history is the target cell, right? I hope that makes things clear. Okay. There are few images from you. I'll just go through the images. I'll tell you one classical things for you for every image. The other name of target cell is, yes, Swati. Any cause which can cause myelofibrosis will result in target cell, whatever be the cause, be it primary or secondary. Fine. Other name of target cell is codocyte. My first possibility is TAL. If not, sickle can have target cells. Severe iron deficiency anemia also can have target cells. I'm just going to go with one point. Thalassemia, target cells. Right? These are acanthocytes. Acanthocytes will have irregular projections. It will not be regular. There will be irregular projections, and acanthocytes will be blunt. They won't be sharp. The first thing for me is liver failure. But I'm sure whenever your entrance preparing, guys, when you remember acanthocytes, the first thing invariably comes out is A beta lipoproteinemia, right? A beta lipoproteinemia is definitely one of the possibilities, but liver failure is something which I want you to remember, much more common than A beta lipoproteinemia, fine? Echinocytes or as Burst cells, right? Here, there's going to be an uniform blunt projection. If it's uniform and blunt, it's echinocytes or Burst cells. Only 1% to remember, uremia or CKD, right? The classical findings in where you see echinocytes or Burst cells, okay? I'm not going to write where you see this, but I want you to remember this. I have something called as a drepanocytes, which is the other name for sickle cells, right? Do you remember? And that's where it's seen in sickle cell anemia, that's all, right? You can see the sickled RBCs, you can see the sickled RBCs. It's just like a boat. Drepano means boat. It looks like a boat-shaped RBC as a sickled RBC, fine? Okay. Now look at inclusions. RBC inclusions covers your Howell-Jolly bodies, Heinz bodies, your basophilic stippling, all those things for us, fine? The only thing I want you to remember in any inclusion diagnosis, I want you to look at what stain it is, right? The first and the only clue is you have to pick up whether it's Leishman stain or an new methylene blue stain, the supravital stain, right? The clue here in Leishman stain, RBC will be the same red color. In new methylene blue stain, the RBC will be bluish green in color. Now, bluish green color, new methylene blue, that's all fine. If you are able to diagnose this, that's enough for me. Rest everything you guys will answer. Just give me next 5 minutes. You can diagnose almost every inclusion required for a pathologist to diagnose, right? It's very, very simple. So definitely it will take care of your exams, right? You have to look how many inclusions are there. If it's a single inclusion, when I say single inclusion, let's assume I'm having an RBC like this. I'm having a tiny blue dot. That's what I mean by single inclusion. A single inclusion in Leishman stain, it is Howell-Jolly bodies. In new methyl blue stain, it is your Heinz bodies. Next, to look whether it's multiple inclusion. If it's multiple inclusion, again I have slight variation. Look whether they are uniform. When I say uniform, I'll just draw a cell for an uniform inclusion. I'm having a cell uniformly distributed blue dots. That's what I mean by uniform inclusions all over, right? Uniform inclusion in a Leishman stain, I want you to think of basophilic stippling. Okay. In a new methylene blue stain, uniform inclusion, multiple inclusion, think of your golf ball inclusion. Golf ball inclusion is seen in alpha thalassemia. Okay, it's seen in HBH disease, the alpha thalassemia variant. Okay, right. Next, if it's multiple and if it is not uniform, when I say not uniform, I have an RBC like this, maybe randomly in one corner, but they are multiple, right? If it's not uniform, what do I think of? In Leishman stain, I think of a inclusion called as Pappenheimer body. Pappenheimer body are iron inclusion seen in sideroblastic anemias. Fine. It is seen in sideroblastic anemias. In a new methylene blue stain, it's a normal reticulocyte. A normal reticulocyte looks like that. Fine. Okay. It's very simple to remember. I hope I am not hiding that. Sorry if I'm hiding. Just look at Leishman or new methylene blue. Single in Leishman Hobel-Joly, single in new methylene blue Heinz bodies, multiple in Leishman basophilic sibling, multiple in new methylene blue your golf ball inclusion, multiple non-uniform in Leishman your Pappenheimer, and normal reticulocyte in new methylene blue, right? Just, I want you guys now fastest finger first. I'm going to show you images. The first question I want you to answer to yourself is Leishman or new methylene blue. Second question, single or multiple. Third, write the answer. That's all. Leishman or new methylene blue? RBCs are bluish green in color, so obviously new methylene blue. These are my inclusions. Single or multiple? Multiple. Uniform or not? Uniform. As your perfect golf ball inclusion. Seen in HBH disease or alpha thalassemia. Clear? That's how we're going to use the flowcharts. Leishman or new methylene blue, don't make an error there. Single or multiple, uniform or not uniform, right? Leishman, new methylene blue. Leishman, right? Single or multiple? Look at this. Multiple. Uniform or not uniform? Obviously uniform. Diagnosis, that's your basophilic stippling. If you don't make a mistake in Leishman or new methylene blue, and if you remember the flowchart, you can diagnose, like I said, all the inclusions required for you. Right? Leishman, new methylene blue. Leishman, single, multiple. Multiple inclusions. Uniform or not? Not uniform. Pappenheimer body. You will remember it. You will remember it for sure, right? It's a simple thing. Leishman, new methylene blue. New methylene blue. See, you have to differentiate these two. I'm sure you can differentiate these two, right? One is Leishman, one is new methylene blue. If that's done, rest everything is done. New methylene blue, single inclusion, that's your Heinz body. These are inclusions. When I say single inclusion, one inclusion in an RBC. That's what I mean by single inclusion, fine? Next. Leishman, single inclusion, Hobel-Joly bodies. Fine? I hope you'll be able to answer it, fine? Just remember the flowchart, Leishman or new methylene blue, single or multiple, uniform or not uniform. And definitely you'll know what to diagnose it, right? If you are writing notes, great. If not, take a screenshot of it. I'll send you the PDF post class. Keep it with you. Read it a day before the exam because it's very, very important for you to remember it. Fine. Okay. Okay. So now I think I'll have a short break and I'll come back maybe after 5 minutes, 10 minutes. How long you want to break? I'll come up with the break maybe in 10 minutes. It's 7:04. I'll start back by 7:15. Fine. We'll start with WBCs. Maybe a little bit more time. We'll try to complete WBCs and maybe a little bit of systemic pathology as well. Fine. Though the timer will say 15 minutes, I don't have the 10-minute timer, but I'll come back exactly at 7:15 p.m. Fine. So maybe have a cup of coffee or a water, or if you want lunch, grab your lunch and come back and let's learn more together by 7:15. Fine. Great. 10 minutes looks good. Great. See you soon. Hello guys, can you see me? Am I audible and visible? Welcome back. So we will continue with WBCs. I hope I'm audible and visible. If so, just give me yes, whomever was online. Okay, we will start and we will go ahead with WBC disorders. Said, it's bang on. We'll start at 7:15. So about WBC disorders, I'll do the same thing like what I did for RBC disorders, because again, the questions, be it FMG or NEET or INICET or next whatever comes, it's going to be the approach, right? Hi Azad. Because most of the WBC disorders, be it lymphoma, the finding is going to be lymphadenopathy. Leukemia, my finding is going to be your pancytopenia or bleeding gums or something like that. But again, having said that, there are few pointers, few classical pointers which tells me yes, this is most likely this type of it. Fine. Assalamu alaikum, Azhar. Fine. Okay, so we are just going to look at the pointers, then we'll go with the approach, and as usual, we'll solve a couple of questions based on that. Hopefully, we'll learn more together, right? So if you're ready for the game, let's start. So in WBCs, whenever you have any WBC disorders, we have two things. One is your leukemia, the other is your lymphomas, right? It's leukemia and lymphomas. Both of them are malignant. Both of them are definitely malignant neoplasm, right? So whatever may be it, leukemia, lymphoma, the approach is going to be simple. First, we'll look for leukemia, then we'll look for lymphomas, right? When you go for leukemias, the leukemia, we'll see leukemia as a neoplasm where it originates from the bone marrow or the blood. Lymphoma is a neoplasm which originates from the hematolymphoid tissue. That's the solid hematolymphoid tissue. That's a basic difference. The first step in any leukemia, the common clinical history for most of the leukemia, for most of the acute leukemia will be cytopenia related, maybe fatigue due to anemia or bleeding spots due to thrombocytopenia. That's the common one, right? Hello, Charlotte. Right? For chronic leukemias, chronic lymphoid leukemia like CLL and CML, the classical history of CLL is your generalized lymphadenopathy. Okay, generalized lymphadenopathy, that's a classical history for CLL and an elderly patient. Okay, and classical history of CML, the splenomegaly, the massosplenomegaly, that's a classical history of CML. Fine, the massively enlarged spleen, or due to that, I'm having a left hypochondrial pain as a classical history of a CML, right? So with the history, I cannot exactly pinpoint to a diagnosis. I'm going to do a peripheral smear. When you have a peripheral smear, be it acute or chronic leukemia, there's going to be something called as blast. Any leukemia is going to have blast, right? I'm going to look at the blast. So how do I diagnose blast? That's the next question for me. When you have blast, the first thing in diagnosing blast is the size. It's going to be at least 2 or more times the size of RBC. If you definitely know the RBC size. If the cell is more than 2 times the size of RBC, I'm going to call it a blast. That's a blast. Second question for me, whether lymphoblast or a myeloblast. The easiest clue for me is lymphoblast has no granules, no OR rods. Okay, and myeloblast has both granules and OR rods. That's how I differentiate lympho and myeloblast. Myeloblast will have granules will be present, and also OR rods will be present. Okay, if it's granules and OR rods present, I'm going to call it a myeloblast, right? So I know how to identify a blast, how to call it lymphoblast, how to call it myeloblast, right? And I'm just going to add one marker for here for our ease and convenience. PAS is positive in a lymphoblast in a dot-like fashion. Here, SBB is positive and also MPO, myeloperoxidase, is positive in a myeloblast. And MPO is definitely the best marker because even in inflammation we saw MPO is present, right? Okay. Next thing for me is count the percentage, because percentage of blast tells me whether it's an acute leukemia or a chronic leukemia. Because what happens here is we call leukemia acute and chronic not based on the time. Till now we call acute and chronic based on the time, right? Acute inflammation and chronic inflammation. Here it's never based on time. It's based on the immature cell. Blast or immature cell, right? If I'm having more than or equal to 20% blast, BM for bone marrow, either in bone marrow or peripheral smear, I call it an acute leukemia. If it's less than that, okay, if it's less than 20% blast in bone marrow or in peripheral smear, it's going to be chronic leukemia or myeloproliferative neoplasms or something of that sort, right? As a difference between acute and chronic leukemia, right? Now let's come to this. See, because acute leukemia again is most of the questions these days they ask based on what is the next step. So you have to know the next step what to do. Let's assume there's a patient with fatigue, bleeding spots. You've done a peripheral smear. You have seen that in peripheral smear there is, let's say, 30% myeloblast. I want you guys to comment here. I'm going to repeat this clinical scenario again. A patient with fatigue, breathlessness came or bleeding spots came. Peripheral smear was done and it was said to have 30% myeloblast. What is your next step? Do you need a bone marrow aspiration in this patient or not? Bone marrow examination required or not? Because next step always varies a lot. You don't want a bone marrow examination here. You directly go with flow cytometry. This is very, very important because I have good amount of blast in my peripheral smear. 30% cells is enough for me to do a flow cytometry and tell me what type of leukemia it is. That's enough for me. I don't want a bone marrow examination. Please do not do a bone marrow examination unnecessarily because it's very, very painful and it has no value here, right? Let's say the patient, second scenario, the patient has, let's say, 12% blast in peripheral smear. Now here, should I do bone marrow examination or directly I can go for flow cytometry? Here you have to do bone marrow examination. You need bone marrow because let's say if in bone marrow, we have done a bone marrow and blast percentage is like 45%. Acute or chronic? Acute leukemia, right? Because I'm going up more than 20% either in bone marrow or in peripheral smear. So if my peripheral smear is less blast and my bone marrow has more blast, still I'm going to call it an acute leukemia only. It's an acute leukemia based on myeloid or lymphoid, it changes, right? That's one. So this type of leukemia, I'm going to give a term. Peripheral smear doesn't have enough blast, but bone marrow has blast. We call them an subleukemic leukemia. Okay, peripheral smear, there's less blast, slightly less blast than expected, but it's fine. Bone marrow had good amount of blast. It's still a leukemia, but subleukemic leukemia. Fine. Third scenario. The patient had 12% blast in peripheral smear, and let's say 15% blast in bone marrow. But we did your genetic analysis, and the patient had translocation 821. Is it a leukemia or not? Is it an acute leukemia or not? I just want you guys to comment here. 12% in peripheral smear, 15% in bone marrow. Blast. Is it an acute leukemia or not an acute leukemia? Just tell me that answer. Yes, no. I want you guys to comment. It's fine if you're wrong, but do comment. It's still an acute leukemia. Right? Because there are few exceptions for this blast percentage. Exceptions are always MCQ. The exceptions, there are 3 genetic abnormalities: translocation 821, translocation 1517, and inversion 16, right? All these 3 things, if I have any of these 3, if you have any of these translocation which doesn't require my 20% cutoff of blast percentage, okay, so this is also an acute leukemia because it has 821, right? Because of the translocation, I can call it an acute leukemia. Okay? So please remember this. There are scenarios where I need not have this cutoff percentage. It's always 20 only. There are few places in Nelson. Dominator, we'll see you later. Right? Okay. There are few exceptions and few places in Nelson which says that the percentage is more than 30%. It is wrong. It's only more than 20%, right? If it's more than 20% in peripheral smear, they directly go slow. Less than 20% peripheral smear, do a bone marrow. If it's more than 20%, go slow. Both, let's look at genetics. If any of these genetics, still it's acute leukemia. If not, let's look like myelodysplastic syndrome or a chronic leukemia, something of that sort. Fine. Okay. That's how you're going to approach your leukemia. Fine. Now, like I said, there are few pointers. Pointers to tell what diagnosis it is. For an ALL child with generalized lymphadenopathy. If you have a question, child with generalized lymphadenopathy, think of an BALL, because B cell type ALL is the common one, right? BALL, right? Child ALL with mediastinal involvement. Think of an T type of ALL, because T has the mediastinal thymic dependent T cells, right? TALL, that's one different type, and TALL will definitely have worse prognosis compared to your BALL, right? Next for you, for us it's your AML. There are very few AML which is classical points. Rest of them are just like a child or an adult with fatigue, your purpura or your fatigue. That's all. Microscopy will show myeloblasts and or rods, right? History wise, there are few things. AML M4, AML M5. These are few things which classically present with gum hyperplasia. See, I want you to be very careful because quite a few of your seniors have done mistakes here. Gum bleeding and gum hyperplasia is not the same. Okay, gum bleeding is totally different, gum hyperplasia is totally different, because when there's a reduced platelet count, thrombocytopenia, also gum bleeds. This is totally different from hyperplasia. When you have gum hyperplasia, it's called a scleroma, extramedullary blast. Think of M4, M5. Okay. Again, few characteristic finding. AML M3 will present the DIC, disseminated intravascular coagulation. Classical finding for AML M3. Look for that. Fine. AML M7 will have myelofibrosis. Very classical. It's megakaryoblast leukemia, and it's also commonly as to with Down syndrome, right? A few pointers to say, okay, this is most likely this type of AML, right? I'm not saying this is enough, but even in scenario based question, I don't want to wait till CD markers. In a very low place, I want you to diagnose them, right? So you have ALL, these are pointers, right? For CLL, like I already said, it's elderly with your lymphadenopathy generalized, plus one more thing, elderly, your generalized lymphadenopathy, and your classical finding of smut cells. For an undergraduate, you see smut cells, my only diagnosis is CLL, right? Chronic lymphoid leukemia. And for CML, we have massive spleen, massively enlarged spleen. That's one of the classical finding. Which part, Azad? Which part you want me to repeat? Can you tell? You have your leukocytosis with basophilia. Basophils, if you look at basophils, there's only one condition where there'll be basophilia. If there's basophilia in the question, please diagnose CML. Not just in your MCQ, even in your real life, you see a patient with like 5-6% basophils, the first probability is your myeloid neoplasms, right? Because basophil is hardly like 0 to 1%. A very rare cause of basophilia apart from your leukemias, fine? Okay. And there may be something called as shift to left. Shift to left means I'll have lots of precursor cells. And I'll have lots of precursor cells that shift to left, fine? Great, Shisha. Good luck for your residency. Okay. So you have CLL, I have CML, you have ALL, you have AML, right? We have done with all the leukemias. Look at this. These are the clues for us. Child lymphadenopathy BALL, child mediastinal involvement TALL. You have your adult or child with your gum hyperplasia, not bleeding, AML M4 or M5, DIC AML M3, and fibrosis and Down syndrome AML M7. The other AMLs I have not put up, like M2, M1. It doesn't have a classical clinical finding. That's all. Smart cells CLL, classical. Again, your leukocytosis shift to left and your basophilia for CML. Since we are in massive splenomegaly, I just want to add one more point here. I have one more condition with same massively enlarged spleen. It also happens in an elderly person, but the patient will have pancytopenia. Can anyone tell me what could be the probable leukemia? Massive splenomegaly, pancytopenia. I will give you one more clue, but I want you guys to comment. The next clue is these patients also have monocytopenia. It's not just pancytopenia. There'll be monocytopenia. That's a classical finding here. Almost only one diagnosis here. Think of hairy cell leukemia. Because again, don't jump with massive splenomegaly to CML. Look at leukocytosis. Hairy cell leukemia is another extreme. There are no cells. In CML, there's lots of cells, right? So both will present with massive splenomegaly. Both will present in adults. One is leukocytosis, one is pancytopenia, right? Okay, so a few leukemias which I want you to remember. Great. Fine. We know a little bit about leukemias. Simple observation about leukemias, right? We'll go to lymphomas. Because lymphoma is again one big thing, right? I didn't take the second part of sprint. Hopefully, I'll take more free sessions for you and we'll learn more together, right? So lymphomas, I have Hodgkin's lymphoma and I have non-Hodgkin's lymphoma. Hodgkin's lymphoma is only one guy, the RS cell. The Sternberg cell with the background lymphoid population is diagnostic of Hodgkin's lymphoma, right? In Hodgkin's lymphoma, I have classical Hodgkin's lymphoma and you have NLPHL. See, for all lymphoma, the point of diagnosis is only your biopsy and IHC. You cannot diagnose lymphoma on flow cytometry. It's always on biopsy and IHC. Fine, just remember that always. Okay. Next here, in classical Hodgkin's lymphoma, the classical RS cells are CD15, CD30 positive, and PAX5 should be weak. If it is strongly positive, it is not Hodgkin's lymphoma. Please be very, very careful. If PAX5 is strong, it's not classical Hodgkin's. It's something else, right? NLPHL, the same RS cell. We call the RS cell a popcorn variant of RS cell. Okay. You'll have markers which are like CD20 positive, CD45 positive, and here also PAX5 will be positive, but PAX5 will be strongly positive because a classical B cell neoplasm, right? NHL is, lymphomas are based on CD markers only, right? If I get some time, I'll talk about your B cell journey. Once you understand the B cell journey, we can easily remember all the CD markers required for it, right? Hodgkin's simple. You look at the binucleate outside or like a popcorn appearance with a CD marker, you can easily diagnose what type of Hodgkin's it is, right? Now coming to non-Hodgkin's. In Hodgkin's also, there are subtle clues. Hodgkin's lymphomas, clinical clues. History-wise, when to call it Hodgkin's is, they will have an, like, it will be more restricted to one group of lymph nodes. They'll involve one group of lymph nodes. Generally, I'm not saying always, like cervical lesion alone. No, rather than a generalized lymphadenopathy, cervical lymphadenopathy, axillary lymphadenopathy, classical of Hodgkin's. Very, very rarely to have your mesenteric lymph nodes. Very rarely. Extranodal sites. Very rarely. When I say extranodal, abdomen. Burkitt's can happen in intestines. Maltomas can happen in intestine, not Hodgkin's. Hodgkin's very rare. Very rare in Waldeur's ring. See, when you have a lymphoma in either of these places, it's not Hodgkin's lymphoma only. Hodgkin's is extremely rare in these places. Clinical clues, right? One group of lymph nodes, only cervical lymphadenopathy, maybe Hodgkin's. I'm not saying it's only Hodgkin's. Obviously, I need microscopy and markers to diagnose them. That's with Hodgkin's, right? Or not Hodgkin's. Like I said, I'm going to tell one pointer for every non-Hodgkin lymphoma. One of the non-Hodgkin's lymphomas, CLL bar SLL, right? We already know that the smart cells. The second guy for me is mantle. Mantle, the clinical clue, which is classical for mantle, is lymphomatoid polyposis. It looks like a lymphoma. Okay? It's a lymphoma, but they present as polyps. Why this is important is because generally when you have a polyposis, right, intestinal polyposis, the first thing a surgeon is going to think is familial adenomatous polyposis, adenomas. But a lymphoma presenting like a polyp is classical of mantle. And IHC, I want you to remember about one IHC, cyclin D1. There's a PYQ, so I'm saying that cyclin D1 negative mantle are positive for SOX11. It's very, very rare, but since the PYQ, I want you guys to know that, right? The lymphomatoid polyposis, IHC, the classical marker is cyclin D1. I have many other markers, but classical marker is cyclin D1 for me. Next is follicular. Follicular history is classical. A lymphoma present for like 10 years. 10 years lymphadenopathy, follicular. Because mantle or CLL or your marginal or your DLBCL will not be present for 10 years, right? It's very, very slow growing. When you have a history for long, like 10 years, 15 years history, the first thought is follicular. Follicular IHC, again, if I want to go with one immunohistochemistry, I'm going to go with BCL2. See, I'm telling one marker because if you look at this marker, BCL2 positive, most likely follicular. Cyclin D1 positive, most likely mantle, right? Then go to maltomas. Malt is your mucosal lymphoid tissue, right? Understand? Genetic markers for a lymphoma, yes, I would require like a translocation in mantle. I have translocation 11, 14. Follicular, I have translocation 14, 18. But it's not done routinely. The only reason when I can have a 100% sure shot diagnosis with IHC, I don't go for marker. Only when IHC is not perfect, we go for my genetic marker of translocation. Yes, it's important. For an exam point of view, like I said, I'm going for the classical pointers since it's a final touch, right? Maltomas, it's extranodal mostly. Like if you have a history of any chronic inflammation, that's one of the clue for maltoma. I'll give you one example. A chronic H. pylori gastritis can result in gastric maltoma. Okay. Hashimoto's thyroiditis, chronic inflammation, can result in thyroid maltoma. Sjogren's syndrome can result in salivary gland maltomas, lacrimal gland maltomas, right? There should be a chronic etiology there. That's one of the clues they okay, it's maltomas, fine. Okay, and one IHC for maltoma. Again, there are many, many IHC, but one IHC is CD43. CD43 positive, I'm going to think of a maltoma for sure. Okay. Burkitt's. Burkitt's is very classical. Till now, we have seen quite a few lymphomas. All of them are seen in adults, young adults or elderly. Burkitt's is the only lymphoma, mostly only lymphoma, apart from your ALL, leukemia lymphoma, this is the only lymphoma which will be seen in children. Even if you remember, whenever you think of Burkitt's, one image will pop up to your head. African kid with the jaw swelling. Kids, non-Hodgkin's lymphoma, Burkitt's. That's the dictum, right? Most likely, be it an abdomen presenting with interception or a cervical node. Kids, if it's a lymphoma, think of Burkitt. And obviously, my microscope, no one will forget it, right? The starry sky appearance. Maybe one of the important, or maybe the only microscopic finding you will be 100% confident throughout your life, the starry sky appearance, right? IHC, again, I'm going with one IHC marker, or CMIC. Instead, adding to your point, in Burkitt's, the translocation is 814. In 8th chromosome, I have CMIC. In follicular, translocation is 1418. 18th chromosome, I have BCL2. In mantle, translocation is 1114. 11th chromosome, I have cyclin D1. In other words, I am testing the same translocation in a biopsy in the form of IHC. That's all, fine. Okay. These are the classical pointers. If it fits into nothing, and the question says microscopy shows a large lymphoid cells. Okay. It's large lymphoid cells. I want you to think of an DLBCL, that's all. Because DLBCL doesn't have a classical profile. It can have a mixture profile. CD20 positive, large lymphoid cells, it has to be DLBCL, that's all, right? Okay. I hope this will not help you to diagnose everything with 100% certainty, but definitely will give you a clue of where to look for, right? So we have Hodgkin's, we have non-Hodgkin's, we have leukemias as well, right? Again, if you have good handwriting, write it, take a printout, and keep it as a final revision go for you, fine? If you don't have good handwriting, it's like me, maybe use this PDF, save it, because my only concern about PDF is you don't look at the PDF again, right? I don't mind sharing the PDF, but if you're going to look at it and read at it, great, nothing like that, fine? So with that information, let's go ahead and diagnose few questions. Okay, so tell me what's the most likely answer, then we'll discuss something about this question. I'll mute myself for a few seconds. Answer. Anyone? I'm sure you guys know. I just wanted you guys to comment. That's all. It's perfect. It's very simple, right? Though we have not read this, it's a very classical one. It's a multiple myeloma, right? Thank you, Asad. This finding here, I'm sure quite a few of you must have diagnosed the condition with this mott cell, right? That's a classical mott cell, which is like mott is like a mulberry. It's like a berry. It's like multiple berries inside. The classical thing of mott cell. Look at the history: 65-year-old, complaints of low backache, and on electrophoresis shows to demonstrate an increased amount of IgG levels, calcium levels is elevated, creatine levels are elevated, skull shows multiple punch out lesions. All of them are characteristic findings of multiple myeloma, right? See, the good thing about you guys is, though you think that you don't know much about lymphoma, we didn't even talk about multiple myeloma, but still you are able to diagnose multiple myeloma, right? That's a good thing about a scenario-based question. You can definitely identify them at least with one pointer, right? Now we'll deep dive and understand about myeloma or plasma cell neoplasms in general, fine? Because plasma cell neoplasms are also an important point of view. Yeah, that's enough. Like Nisrak said, one clue is enough for me to diagnose. That's the beauty of your scenario-based question. See, if Nisrak said because of punched out lesion he picked it up. Let's say if the question didn't have punched out lesion, he must have struggled. Some of you must have picked it up with IgL monoclonal protein. That's enough. Some of you must have looked at the mott cell and diagnosed it. That's enough. I want to diagnose at the end of the day. No one cares how you diagnose, right? Once you get the first rank, you say that from 11th standard itself, I started reading your Harrison. No one is going to believe you anyway, fine? Okay. Now let's look at your plasma cell dyscrasias. Because plasma cell neoplasms are important point of view. So once we know the diagnosis, when medicine, they'll definitely cover how to treat the plasma cell neoplasms, right? Very simple thing. I have three different things. One is called as MGUS, monoclonal gammopathy of undetermined significance. Like your cervical neoplasm, CAN 1, 2, 3, and then cervical cancer. Like that, I have stages. Before becoming myeloma, I have MGUS, I have smoldering myeloma, okay? Then I have multiple myeloma or your plasma cell myeloma, or I can just call it a myeloma, fine? So all these are your three different stages of this, right? Okay. Roni, Raj, good evening, and we are in the middle of that. For dedicated batches, just give us some time. We'll definitely put through it. Fine. MGUS, smoldering myeloma, and multiple myeloma. I'm having three different types and three different variables. The first variable for me is, I'll just erase this thing, percentage of bone marrow plasma cell. Okay, that's a first variable. The second variable, I'm going to club two things. I'm sure you must have heard about monoclonal M spike, right? Either it can be M spike or it can be serum levels. M spike is just an appearance. When I say serum levels, you have more than 3 gram per deciliter, which is quantitative. Either of this. That's the second variable. Third variable, CRAP criteria, or I have a new criteria called as slim. Okay, either CRAP or slim. I'll tell you what is CRAP and what a slim means very soon. Fine. So these are three variables. I have three different types of them. That's all. Fine. So when I have in MGUS, the number of plasma cells in the bone marrow, these are all bone marrow plasma cells, should be less than 10%. It need not have a M spike. Charlotte, can you this soon? Maybe once it goes, you can go back and catch it up. Fine. If it's need not have an M spike, and the serum protein can be less than 3 gram per deciliter, right? CRAB or slim, no CRAB criteria, no slim criteria. Fine. We're discussing about plasma cell neoplasms. When it comes to smoldering myeloma, the percentage of plasma cells can be from 10 to 60 percentage. The older criteria said greater than 10 percentage. Now I have kept an upper limit 10 to 60 only. This may or may not be present. Most of the time will be present only. It will be more than 3 grams and M spike will be there. But there are few like 3-4% of non-secretory myelomas. They might not have this spike, right? So I'm writing plus or minus, but predominantly it's plus only. Fine? Predominantly it's plus. Sometimes it may not be present. No crab and slim criteria again. Greater than 10%, again plus predominantly, and subtle amount of minus because of non-secondary myeloma, but crab and slim criteria present. Only when crab criteria or slim criteria is present, I'm going to call it a myeloma. Fine. Okay. In other things, it's variable. So this determines whether it's in plasma cell myeloma or not, and the bone marrow percentage also. Now let's look at crab and slim. I'm not going to explain about crab because most of you guys knows about crab, right? Creatinine, your hypercalcemia, renal failure, anemia, and bony lytic lesions. The punched out lesions is the question, right? That's your crab criteria. We look at slim because slim is a new approved criteria. SLIM, right? SLIM. S stands for 60. More than 60% of bone marrow plasma cells. That's an approved abbreviation by WHO. It's not my mnemonic. That's what WHO says. CRAB also is an approved abbreviation. SLIM also is an abbreviation, right? LI. LI stands for light chain ratio. When involved to uninvolved light chain. When this ratio is more than 100, it's considered as a criteria. What do you mean by this involved uninvolved is, let's say I have kappa and lambda. Those are two light chains, right? And I'm assuming that kappa light chain has become neoplastic, which means it will be 100 times more than lambda. If it's 100 times more than lambda, it cannot be due to inflammation or infection. It is 100% neoplastic. That's why I put it as a criteria. Fine. Third is MRI. In MRI, there are more than one focal lesions. See, only reason why we move to slim from crab is slim says, I'm looking at MRI. I'm not waiting for my bone to lyse. I'm not waiting for my kidney to fail. I'm not waiting for anemia to happen and hypercalcemia to happen and destroy my kidney. I'm diagnosing it even before so that I can manage the patient effectively. That's why slim is very, very important. These are also called as biomarkers of malignancy. Okay, both means one and the same, slim or biomarkers of malignancy in myeloma. I should either have slim, one or more than one is enough, plus your bone marrow percentage, or crab plus bone marrow percentage. That's enough to call it myeloma, right? That's about your multiple myeloma diagnosis. It's always based on this. This table is enough. Any permutation combination you can diagnose with this table, right? But whenever you have crab or slim positive, you have to jump to myeloma only, right? So going back to the question, that's a classical model and that's a diagnostic of multiple myeloma, right? Next one, let's see if we can pick it up. I'll mute, keep myself quiet for some time. Answer? It's a simple one, right? 15-year-old present with painful intra-abdominal mass, peripheral lymphadenopathy, patient in night sweats, fever, weight loss is there, biopsy of a lymph node shows finding, which showed translocation 814, right? Okay. Now let's see if we can come to a diagnosis without using much of facts here, right? Because there are lots of pointers here, but I want you to use minimal information to come to a diagnosis. And I'm sure you can definitely come to a diagnosis, right? Hi, Aviral Pandey. Okay. The first thing for me here is 15-year-old. Unlikely to be follicular lymphoma. There is a pediatric follicular lymphoma, but I won't ask that for undergraduate. Unlikely. CML, unlikely. Say I'm ruling out two options just with the first information of 15-year-old, that's all. Then the patient has intra-abdomen mass and peripheral lymphadenopathy. Both are there. See, for me, ALL as well as Burkitt's can happen in a 15-year-old for sure. But the patient biopsy is taken from a lymph node. If it's a leukemia, I will look at a peripheral smear or a bone marrow, not primarily into a lymph node. Plus, I have the classical thing. That fact, if you know translocation 814 is where, like I said, you have the CMYC getting translocated. It's a classical translocation in Burkitt's, right? So age helps me Intra-abdomen mass helps me because non-Hodgkin's lymphoma can happen in the external location also. Child helps, right? And also genetic analysis helps by diagnose your Burkitt's lymphoma, right? You guys are right. The classical Burkitt's lymphoma, it's not ALL because ALL will have blast. I don't have a percentage of blast here to call it an acute leukemia, and ALL will not have translocation 814. That's diagnostic of a Burkitt's lymphoma, right? Great. The next question, let's see if we can pick it up. Okay, start commenting the answer. Is a 25-year-old present with a history of pallor with petechial bleeding and fever since last 7 days. On examination, there's enlargement of the liver, spleen with sternal tenderness. Which of the following is most likely reason for the explanation of the symptom? I put this question particularly because some of you guys commented on the WhatsApp group that what is the answer here? Is it ALL or AML? Because that's the doubt between those. Say I'll go one by one again so that we can have a clear-cut understanding of what it's about. 25-year-old. That's 1 point against my ALL. Age is important for me, right? Age is very, very important. 25-year-old unlikely to be present as ALL, right? History of pallor, petechial bleeding, and fever since seven days. Kind of looks like cytopenias. Anemia, thrombocytopenia, maybe your leukocytes are reduced, leukopenia. So you will think of aplastic anemia, right? Whenever you have the cytopenias, my first thing is I jump into aplastic anemia. But remember, in aplastic anemia, spleen should not be palpable. If spleen is palpable, if spleen is enlarged, like it's given in the question, there's enlargement of liver and spleen with sternal tenderness, right? Hepatosplenomegaly should never be there in aplastic anemia. If it is there, it is not aplastic anemia, right? That's why every point information is important for me. Next question for me is chronic myeloid. 25-year-old possible, but chronic myeloid leukemia will not present with petechial bleeding. They're present with massive splenomegaly, right? Unlikely again. Sternal tenderness. Sternal tenderness implies there's a sudden increase in the bone marrow or there's bone marrow expansion. Bone marrow expansion is more common in acute leukemia compared to chronic leukemia. So the only option is left for me is acute myelogenous leukemia. I'll repeat again why it is not ALL. Again, liver and spleen are myeloid organs. ALL, that's acute lymphoid leukemia, presents with lymphadenopathy and not with organomegaly. So it's not ALL, answer not a child, not AL. Aplastic anemia because spleen is palpable, not that. Cytopenias are not the way by CML presence. CML presence is massive splenomegaly, right? So it's not CML also. So the only point by ruling out is AML, right? See, this is a recall based question. I'm not sure if there was any other information given in the question which was missed in the process of recall, right? If it's missed, it's fine. Even if it's not there, we can easily rule out other options and come to the right answer. Keep this in mind. If you feel a question is difficult, go retrograde. Retrograde approach will help in difficult questions. What do I mean by that is, look at aplastic anemia, see if it will fit in the scenario. Will not. Chronic myeloid will not. Acute lymphoid will not. I am left with only one, acute myeloid, right? If it's difficult, go retrograde. Sometimes it might definitely help you guys, right? Okay. It's a very simple one. Comment on it and let's learn about it. I'll mute myself for some time. I want you guys to comment on the answer. Okay. 10-year boy with a swollen knee after a trauma. Which of the following conditions is likely to present in this patient? Most likely finding. See, instead of calling it swelling knee after trauma, we can use the term hemarthrosis, right? Because that will make our life much, much easier, right? Hemarthrosis in a young boy, again, that's though gender is not mostly a clue, but in this case, yes, definitely a clue. Young boy with hemarthrosis, X-linked disorder, X-linked inherited disorder, most likely a factor 8 deficiency, right? Or a hemophilia. It could be factor 8 or factor 9 deficiency or hemophilia. We look at other options here. See, von Willebrand disorder, there are three types of von Willebrand diseases. One of them will classically present like hemophilia, but that's a very, very rare von Willebrand disorder, right? Most of them present with like menorrhagia or very subtle ecchymosis or petechiae. They won't present with hemarthrosis. ITP presents with petechiae, not hemarthrosis. Vitamin K deficiency is very almost impossible in a 10-year-old kid, right? And that also presents bleedings and might not present with hematose like this, right? Okay, we look at the approach to your bleeding disorder, hemophilias, right? When you have any bleeding or coagulation disorder, follow the same approach. Always start with history, because history gives me lots of clues. When you have a history of petechiae, purpura, or ecchymosis, I'm dealing with an platelet problem. Could be a thrombocytopenia, could be a platelet function disorder, but I'm dealing with a platelet problem, right? If you have history of like deep-seated bleeding, when I say deep-seated bleeding, which means I'm talking about, like in our case, hemarthrosis, or you can have muscle hematoma, right? If you have an intramuscular hematoma, I'm dealing with a coagulation problem, right? So one is bleeding, the other case is coagulation problem, right? Family history. If family history is present, it's most likely a coagulation problem, because the commonest cause of thrombocytopenia is drugs. Drug-induced thrombocytopenia will not run in families, right? It's a sporadic condition, or viral fever like dengue fever, thrombocytopenia. It's not inherited. If you have an inherited cause, familial history, think of a coagulation disorder. When I say coagulation disorder, which means clotting factor disorder, platelet means abnormality in platelets number or function, right? Then few classical history. Post-trauma, if there's an history of continuous bleeding, I'll tell you the importance of this, or if there is a history of rebleeding, I'll tell you what does rebleeding means first, right? So let's say a person had a cut, blood stopped for some time. After stopping of blood, the person maybe for 4-5 minutes is stopped, again started to bleed again. That is history of rebleeding. History of rebleeding is diagnostic of coagulation disorder, because in coagulation factor or even in your hemophilia, what happens is clotting factors are abnormal, platelets are normal, which means the primary hemostatic plug is normal. Patient had a cut, platelet came and closed the area, but platelet is not permanent. So after some time, it start to rebleeding it as well. Right? Okay. History of continuous bleeding is suggestive of a platelet disorder. Okay. Rajesh, I'll tell you honestly one thing. Every faculty, don't tell to ask any other faculty, and every faculty teaching you here has been teaching the same thing for the past 7-8 years, or even more than that. So it's nothing for us. At the same time, you or anyone listening to this lecture can become better than us if you put your heart and soul into whatever you're going to read. It's time, that's all. The only difference, what makes the difference between you or any of the students and me is I am a bit old. So I read more. I've been remembering for a longer time. That's all, right? You will, I can assure you, if you put the same amount of work, you guys will be at least 2 times better than I am at this point of time. Fine. And all the best. You guys are very, very smart. Use the smartness and please read properly. Fine. Let's come back to this. The continuous bleeding, and I'm having history of rebleeding, right? For coagulation platelet. Only then go for investigations. Till that time, I don't want you to jump to investigations, right? Always the history, family history. Then look at investigations. So CBC value will tell me the platelet count. Okay? The platelet count is reduced, thrombocytopenia. Directly I have the answer, right? I don't need to worry about anything. Peripheral smear can give me few clues. The clues of peripheral smear are very, very important. When you have a clue saying there are giant platelets, okay? The giant platelets, they are huge platelets. Giant platelets is suggestive of ITP, immune thrombocytopenic purpura. That's one, right? Second, let's say there are tiny platelets, microplatelets, small platelets. Though it's not useful for your bleeding coagulation disorder, it's seen in a condition called as Wiskott-Aldrich syndrome. There's one more condition with giant platelets, either ITP or a condition called as Burnett-Solier syndrome. You must have heard about Burnett-Solier syndrome, right? For sure. You guys know more syndromes than anyone can, right? So giant platelets, there are two possibilities. Again, peripheral smear gives me clues for diagnosis, that's all. Then bleeding time, if it is elevated, I'm dealing with a platelet problem, either number or function. Right? Clotting time, if it's elevated, I'm dealing with a coagulation problem. Okay, again, suggest to avoid, that's all. After this only, I'm going to go for your PT, APTT, and TT. Till now, I am not even touched your coagulation test, right? Once everything is done, we go for your coagulation studies, PT, APTT, thrombin time. I'm sure you guys know about PT, APTT, but I'm just going to put in one line. PT takes care of your extrinsic pathway. Extrinsic pathway is your factor 7, right? APTT takes care of your intrinsic pathway. Your 11, your 9, your 12, 8, everything comes in the intrinsic pathway, right? TT takes care of only 1%, fibrinogen. So remember, if thrombin time is prolonged, there's some problem in fibrinogen. It's either being consumed or not being produced. Right? That's very, very important. TT takes care of only 1% fibrinogen. That's all. Fine. With this information, let's look at different permutation combinations and see what could be the answer. Right? The first possibility. PT is prolonged. APTT normal. Thrombin time normal. Platelet count normal. What do you think will be the answer? Everything is normal, only PT is prolonged. Your diagnosis, the first diagnosis should be early onset liver failure. I'm sure you must have jumped for factor 7 deficiency, but factor 7 deficiency are acquired inherited conditions, very, very rare. But when liver fails, factor 7 is one of them with very short half-life, right? So factor 7 deficiency is there, but secondary. But first thing, early onset liver failure. See, if you're intern or post-intern, you will agree with me. Whenever you do a liver function test, especially for surgeries, PT is a component of liver function test, right? Prothrombin time is a component of liver function because liver functions properly, PT will be perfectly normal. Even slight problem, PT will become normal, right? Next, PT normal, APTT prolonged, thrombin time normal, platelet count normal. Again, differential diagnosis, making it a little bit easier. So if it's only APTT prolongation, first think of von Willebrand disease because it's the most common inherited clotting factor defect. Not hemophilia, this is commoner than hemophilia, right? So if APTT is isolated prolonged, first at least rule out von Willebrand. I don't want you to diagnose as von Willebrand, at least rule out von Willebrand. That's very, very important for me here, fine? Okay, then yes, I think of hemophilia. It can be hemophilia A or hemophilia B or any other thing. Any other problems in your intrinsic pathway can be the answer. But 8 and 9 are the common ones, right? Third, PT prolonged, APTT prolonged, thrombin time normal, platelet count normal, right? All these variations, right? PT and APT is prolonged, that's everything is normal. Again, my differential diagnosis, the first thing and the foremost thing I'm going to think of is liver failure because most of the clotting cascade, coagulation cascades are produced by the liver. When liver goes, first to get knocked off is factor 7. After that, one by one, everything will be gone, right? Okay. Next, common pathway defect. See here, TT is normal. So I'm going to have common pathway defect above fibrinogen. Because if fibrinogen is also abnormal, if fibrinogen is abnormal, who will get elevated? Thrombin time will get elevated, right? So some problem above fibrinogen is a concern here, right? Maybe a factor 10, factor 5, thrombin, everything can be abnormal here, which will have both PT and APTT elevated, right? Both PT elevated, TT, APTT elevated. I'll give two slight variations in scenario. thrombin time elevated, platelet count normal. This first scenario. The second scenario is PT elevated, APTT elevated, thrombin time elevated, and your platelet counts are reduced. Two subtle scenario. The only difference is platelet. The first of half platelet is normal. Second one platelet is reduced. If you have this, think of this fibrinogenemia or afibrinogenemia. Okay, because that's a characteristic picture of a fibrinogen abnormality. But in second condition, platelet is also reduced. So some disease is taking my clotting cascade or clotting factor as well as taking away my platelets. That's your consumption coagulopathy or diagnostic of DIC. Disseminated intravascular coagulation. The other term is consumption coagulopathy, right? It consumes all your platelets and clotting factors, and that's how the picture will be, right? PT normal, APTT normal, thrombin time normal, platelet count normal. Still the patient has bleeding episodes. Still the patient is having episodes of bleeding. Still the patient has a little bit of petechiae, purpura, and ecchymosis. What are the possibilities? Can anyone tell? Till now you have been very extremely quiet and disciplined audience. Now make a comment on what could be the probable reasons till the patients are having petechiae, but PT, APT, thrombin time, platelet count, everything is normal. What could be the possibilities? I want you guys to comment. Any possibility? When you have this finding, first think of problems in the vessel. See, because I'm having vessel and blood goes inside them. Either my blood is leaking due to a vessel problem or my blood is not getting clotted. Both can be problematic, right? So when you have all these findings, think of vasculitis. Because vasculitis also will present with purpura, petechiae. But vasculitic purpura will be palpable purpura. That's a difference. So history will help me, examination will help me, right? If it's vasculitis, it will be palpable purpura. And it's a normal man should not have bleeding episodes, right? So it's unlikely to be a normal man. Factor 13 deficiency. Swati, I'll come to that. That's definitely a right answer. Fine. Second for me, scurvy. One of the classical problems in scurvy is gum bleeding, right? You must have read in even your school days. Could be a problem. You can have a problem in collagen. Have a collagen vascular disorder. It could be an Ehlers-Danlos. Collagen is not normal. If collagen is not normal, the vessels are weak. Vessels will break and you'll have petechiae and purpuras for sure. There's a possibility of bleeding as also there, right? If it's something related to platelet or clotting factor, like Swati said, it could be an factor 13 deficiency. Because factor 13 is clot stabilization factor. It's not needed for clot formation. It's needed for stabilizing the clot, that's all. So if clot is formed normally, everything else will be normal, right? This alone will be abnormal, right? Or I have my platelet function disorder. Platelet count is normal. Function is abnormal. Thrombasthenia, Glanzmann thrombasthenia, Bernard-Solé syndrome. That also will have every coagulation factor normal and platelet count being normal, right? So everything is normal in the question and still the patient bleeds. Think of these things. Of these, the first three are not related to bleeding coagulation. The rest of them, last two of them, are definitely related to bleeding and coagulation disorder, right? And if it's a factor 13 deficiency, I'll just name the test used to diagnose. Investigation of choice is urea clot solubility test. And that's here. And in platelet function disorders, investigation of choice is platelet aggregometry. Okay, that's how I'm going to diagnose these conditions. Fine. Okay. Fine. So we are done with little bit overview of bleeding and coagulation disorders as well. Fine. Okay, so what we're done in this lecture is I'm going to call it off a day. We are done with a little bit of general pathology, RBC, WBC, and platelets, right? If you're attempting an FMGE exam, see your goal is 50%. And whatever you have done now, these points will take close to 75-80% of these subjects. Consider on general path and hemat. Systemic path, not much. I'll definitely cover in coming sessions about a little bit about your glomerulonephritis, vasculitis, and your vegetations and what is required for you from systemic pathology point of view, right? So we'll wind up the session. If you have any doubts, do let me know. If not, we'll call it a day. Any doubts? No? We don't have doubts, right? So if you have any doubts later also, do let me know. I'll be more than happy to answer your queries. If I know, I'll definitely answer. If I don't know, I'll definitely ask someone's help, or I'll read and definitely answer, right? So thank you for your time. Thank you for your patient listening as well. And hopefully we'll see more things and learn more things together. Thank you, Nusra. And definitely we'll become amazing doctors, right? Perseverance is the only thing which is going to make us great. Keep reading, not for exams, because you're going to treat someone and you're going to be important for someone's life and future, right?